Hello, hi guys. I hope I'm audible and visible to you properly. Okay, hi guys. Okay, sorry for a bit of a delay. There was some place where I was a bit stuck. That's why there was a bit of a delay on my end in starting this particular session. But I have started. I will not waste any further time and I'll just quickly start. What we are going to do today, I hope that you understand that we are going to discuss 100 important image-based questions. Okay, so what we are going to do, we are going to discuss 100 important image-based questions. Okay, now I will be fast because we have to cover, let's say, 100 questions. It will take around 5 hours, and yeah, and I'll be a bit fast. That's fine, but I want you guys to kind of put your answers in the comment box. Okay, I want you to do that. Okay, so without wasting any further time, let's start with the first question. So here, what you need to understand is that I'll read it because I think it's not visible to you. What is the pressure generated in this particular type of the wound closure? Okay, so what is this? First of all, tell me what is this? Yes, it's around 5 to 6 hours of the class, right? Yeah. So what is this? This is what is a vacuum assisted closure. So what is this? This is a vac dressing. And what is the what you call as the pressure which is generated in this particular vac dressing? What is the answer over here? That is minus 125. Okay, so where do you use this particular vac dressing? So anywhere where you basically feel that, you know what, there is a wound, okay, where you need to fasten the granulation tissue. Okay, wherever you need to fasten the formation of the granulation tissue, this is the area, or this is the place where you basically use this particular vacuum assisted closure. And if I ask you, what is a prerequisite, or what is so what is a prerequisite for for performing this particular vacuum assisted closure, vac dressing? So the prerequisite for performing the vac dressing is that there should be no slough and there should be no infection in the base of the wound. Okay, so there will be no slough, there should be no infection at the base of the wound before you are performing this vacuum assisted closure. Okay, right? So this is what is the primary thing which you need to understand in the vacuum assisted closure. Okay, now let's move on to the next question. There's a patient with a testicular swelling, and the patient on the operation was shown, and this is basically the gross specimen of this particular patient. So what is the diagnosis over here? So can you please help me? What is this particular pathological specimen? Is it like the specimen of your seminoma, teratoma, yolk sac tumor, lymphoma? What is the answer over here? No, it is not seminoma. It is a teratoma, guys. Okay, so what is it? It is teratoma. So please try to understand what kind of a pictures, what are you going to see. Okay, first focus over here. So what are you basically finding? So you are finding that this is a solid cystic mass. Okay, what is this? This is what is a solid cystic mass. Okay, so I hope you're able to understand this is what is the solid component, this is what is the cystic component. So this solid cystic, a heterogeneous kind of a mass, this is what you basically find in the patients with the teratoma. In the seminoma, what you're going to find, seminoma is also referred to as your potato tumor. So why this is basically called as a potato tumor? Because on the cross section, what it has, it has a homogeneous, okay, it has a homogeneous kind of a structure. Okay, it is a homogeneous kind of a structure with very few areas of the necrosis can be there, but broadly it is basically having a homogeneous kind of a structure. Okay, now what is the characteristic thing about the lymphoma? Okay, what is the characteristic thing about the lymphoma? The characteristic thing about the lymphoma are two. First, it is common in an elderly patients. Okay, elderly patients, that is more than 60 years of age, and it tends to be bilateral. Okay, so if at all, let's say a elderly patient comes to you with a bilateral testicular mass, they are basically talking about lymphoma. Okay, so elderly patient is basically talking about your lymphoma. And what about the yolk sac tumor? Can you tell me about something about the yolk sac tumor? So yolk sac tumor is a kind of a condition which is basically present in the young population. Okay, it is present in the young population, and what it has something which is called as a Schiller dual bodies. Okay, so they can ask you this Schiller dual bodies are basically present in. So Schiller dual bodies are basically present in the patients with the yolk sac tumor. Okay, right. So दोनों के pictures में difference का कोई तरीका. Okay, so Utkarsh, what you need to understand, as I told you, in the teratoma there's going to be a heterogeneous kind of a thing, right? So here there is a solid cystic mass. In the seminoma there's going to be a homogeneous kind of a solid mass. Okay, that is what you need to understand over here. And no hairs and teeth, that's fine. So every time the hair and teeth should not be present in the teratoma. So don't think that, you know, every time in the teratoma there will be hair and teeth. Yes, okay, so I hope you understood how you distinguish between the teratoma and the seminoma. Solid cystic heterogeneous mass, teratoma, and seminoma is going to be the homogeneous mass. Okay, got it? Okay, now let's move to the next question. Now this is something which you should know. There's a patient who has come to you with a bilious vomiting. Okay, so this is a small child which is coming to you with a bilious vomiting, and then let's say you did a CECT scan of this particular patient. What is the diagnosis of this? Okay, so I'll just zoom in on the image, and I hope you are able to appreciate this particular kind of a arrow. Now, I'll just show you the images. What is this? Is it like a duodenal atresia, midgut volvulus, annular pancreas, or the ileal atresia? Now, this is not a very simple question. So just try to look at the arrow. What is this particular arrow trying to tell you? Okay, so the arrow is basically trying to tell you about the whirlpool sign. Okay, so every bilious vomiting is not the duodenal atresia, guys. Okay, so every bilious vomiting is not the duodenal atresia. What is this particular arrow is trying to tell you? This arrow is trying to tell you something which is called as a whirlpool sign. Okay, what is this basically trying to tell you? Whirlpool sign, which you basically find in the patients with the midgut volvulus. Okay, so what are you basically seeing over here? This is what is a midgut volvulus. Are you appreciating this particular point? I'll just show it to you. Okay, so I hope. Okay, how do you kind of understand this? Okay, so are you understanding this white colored? Are you able to see this particular white colored central portion over here? So what is this white colored central portion? This is what is your mesenteric artery. Okay, this is what is your mesenteric artery, and the intestines are basically wrapping around this particular mesenteric artery, and this is what is referred to as your whirlpool sign. Okay, so that is what is referred to as your whirlpool sign. So centrally what we have is a mesenteric artery, and surrounding this you have this particular intestine which is wrapping it up. So this is what is your whirlpool sign. Okay, so please try to understand this point, the whirlpool sign in the midgut volvulus. Okay, now what happens in the midgut volvulus is, so there is the problem with the rotation of the gut. So what you need to understand, inside the embryonic period there is the physiological rotation of the gut. The most important thing in this particular midgut volvulus is that there is a Ladd's band. Okay, so there is a Ladd's band which is basically not allowing the intestines to kind of go into the normal location. So because of this, what happens that the stalk of this particular mesentery becomes very narrow, and now it can basically kind of rotate on itself. So the central portion which we are seeing, that is what was here superior mesenteric artery, SMA. Okay, now here, what is the name of the surgery in these particular patients in the midgut volvulus? What is the name of the surgery which you basically perform? The name of the surgery which you basically perform in these particular patients is something which is called as a as a Ladd's operation. Okay, so Ladd's operation. So what you basically have to do in this, that you have to kind of do an exploratory laparotomy, you have to rotate this particular gut, and you have to cut this particular Ladd's band. Okay, so this particular Ladd band, it basically needs to be cut, and because it is, once it's going to be cut, only then the cecum and everything will be able to be brought down to the normal location. Now you understand my point? So I hope you have understood. Every bilious vomiting is not the duodenal atresia. You have to look at over here. Here the image is a very important clue, and if you look at the arrow in a very proper manner, you will be able to appreciate a whirlpool sign which is basically present in the midgut volvulus. Okay, what sign are you going to find in the patients with the duodenal atresia? In the duodenal atresia, you are going to find a double bubble sign. Okay, you're going to find a double bubble sign. So double bubble sign is basically what you find in the patients with the duodenal atresia, as well as in the patients with an annular pancreas. So we will talk about these particular things in a in the subsequent questions. Okay, now let's move on to the next question. So okay, now this is one of the very simple questions. A patient was admitted with the CT scan for some particular condition, which was incidentally the patient was found to have this particular thing. Okay, so image has been shown to you. What is the incidental finding in this particular patient? So what are you basically able to see over here? What is this? So yes, absolutely right. What is this? This is what is a horseshoe kidney. Okay, so what is this? This is basically your horseshoe kidney. So what you need to understand about the horseshoe kidney is that the formation of the kidneys. Okay, so in general, if you wish to understand about the kidneys, what you need to understand, the kidneys, they basically form in the pelvis. Okay, so kidneys, they basically form in the pelvis, and then they come to lie into the retroperitoneum. Okay, so kidneys, they basically form in the pelvis and then they basically come to lie in the retroperitoneum. Now what you need to understand is that so what happens is during the embryological period there is an ascent of the kidney which basically takes place. Now if at all there is a patient who is having a horseshoe kidney, okay, so if at all there is a patient who is having a horseshoe kidney, what is going to happen? The lower poles of the kidneys are basically joined together. So now when the kidneys are basically ascending up, this ascent of the kidney can be restricted by something. Okay, so please try to understand, if at all there is a horseshoe kidney, the ascent of the kidney is restricted by a artery. So which is the artery which is basically going to restrict this ascent of the kidney? Very, very important MCQ. Please try to understand. It is what is your inferior mesenteric artery. A very important MCQ, guys. Okay, so I hope you remember this. So the ascent of the kidney is basically what you call as restricted by the inferior mesenteric artery. Now if I ask you about a couple of more questions about this, so what is the location of the isthmus? Okay, so what is the location or what is the level at which the isthmus basically lies? Isthmus. Okay, so the isthmus basically lies at the level of what? It lies at the level of, at the junction of L2, L3. Okay, so please try to understand. So the inframesenteric artery, it rises at the level of L2 and the isthmus basically lies a level below that. Okay, because it is restricted by the inframesenteric artery. So the isthmus is basically going to lie at the level of L2, L3. Okay, I hope you have understood this particular point. So this is very, 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 very important thing which you need to understand about the horseshoe kidney. Okay, so the patients are basically asymptomatic. Okay, so what are the patients? Patients are usually asymptomatic. They can come to you with a urinary tract infection or they can come to you with the stones, but most of these particular patients, most of the patients are asymptomatic. Okay, what are they? They are asymptomatic. Okay, I hope you are able to understand this particular point. Most of the patients are asymptomatic. Okay, now let's talk about this particular thing. Okay, so what is the diagnosis of this particular patient? Okay, so what is the diagnosis? Is it like the diagnosis is the patients are having retroperitoneal fibrosis, pelvic lipomatosis, retrocaval ureter, or the POG obstruction? So what do you think? What is the diagnosis of this particular patients? Yes, hydronephrosis can be seen, POG obstruction. What else? Everybody is wanting to say it as a POG obstruction. Okay, nobody is in the, yes, absolutely right. Okay, so finally people have started to say that it is a retrocaval ureter. Okay, so yes guys, so what is this? This is what is a retrocaval ureter. Are you able to appreciate this? Okay, anybody is in the mood of having some fishing done? So this is what is your fish hook sign. Okay, so what you have is, this is what is your fish hook sign, which is basically a diagnosis of your retrocaval ureter. So what is a retrocaval ureter? Let's try to understand this. Okay, normally what happens is that we have a kidney and the ureter basically travels in front of the IVC. Okay, it basically travels in front of the IVC. But if at all during the embryological period, if at all there is a like a patient in whom the ureter is basically going behind this particular IVC. Okay, so let's say if at all the ureter basically goes behind this particular IVC, then what is going to happen? Then the like the urine and everything will get stagnated over here, and what the patients are going to find? Patients are going to find this characteristic fish hook ureter. Okay, so please try to understand a very, very characteristic feature of this is, what is this called as? It is called as a fish hook ureter. Okay, so this fish hook ureter is a characteristic finding of a retrocaval ureter. What is a retrocaval ureter? That is an embryological anomaly where the ureter is basically passing behind the infravena cava. It is a embryological anomaly. It might appear like a, okay, so yes, hydronephrosis is there, but hydronephrosis is because of the retrocaval ureter. Okay, so I hope you understood. This is what is called as a fish hook ureter. What is an investigation of choice over here? So yes, you can perform an IVP or the CT IVP, whatever you want to call it. You can perform those particular stuff. And what about the management is reimplantation. So investigation of choice is your, let's say, IVP or a CT IVP, whatever you want to call it, CT scan or IVP. That is what you need to understand. And the management over here is what you call as a So what you basically do is you cut that particular ureter, you bring it kind of in front of the IVC, and then you do the ureterostomy, or you basically kind of what you call as to establish the continuity of the ureter. So what you call as a surgical replacement of that particular ureter in front of the infravena cava. That is what is the management of these particular patients. Okay, so sir, in this case we will do the ureterolysis. No, ureterolysis. Okay, please try to understand. Every terminology has its own meaning. Okay, ureterolysis. Ureterolysis you are going to do when the ureter is basically densely adhered somewhere. Okay, so ureterolysis will be done in which particular scenario? If at all there is a patient who is having a retroperitoneal fibrosis. Okay, so here the ureter is really not that adhered, right? I mean, obviously you'll have to kind of dissect the ureter, but it is not that kind of difficult. Only just behind this particular infravena cava, you are not able to kind of, sometimes you're not able to kind of dissect the ureter. That's fine. You can cut the ureter at the two portions and then you can anastomose it. But in the patients with the retroperitoneal fibrosis, the entire retroperitoneum has become very, very thickened, and now the ureters have kind of gone medially, and there is what is the medial bending of the ureter. There the treatment is basically your ureterolysis. Okay, I hope you have understood, Shubham bhai, right? I hope you have understood this point. Okay, right, so that is about the retrocaval ureter. Now this is a repeat question from your aims, which was asked, let's say, a couple of years back. So what is the best position for the patients to insert this particular tube? Okay, so what is this? This is basically your nasogastric tube, right? Okay, what is this? This is what is a nasogastric tube, and what is the best position in which you can insert this particular nasogastric tube? Can you please help me with this? Okay, so what is the best position in which you can insert this particular nasogastric tube? Yes, it is in the sitting position with the neck flexed. Okay, so please try to, let's talk a bit about your nasogastric tube. So nasogastric tube, the best position, nasogastric tube. Okay, so what is the best position to kind of insert this? Okay, so the best position to insert this is basically sitting with the neck flexed. Okay, sitting with the neck flexed. This is what is the best position to kind of insert it. Okay, in the unconscious patients, obviously lying down position with the neck flexed, that's fine. But if at all the patient is able to sit, yes, you will ask the patients to kind of sit down, that's fine. Okay, now once you have put this particular nasogastric tube, what is the best method to check for the position? Okay, so you want to understand that, you know what, whether this particular nasogastric tube has reached to the stomach or not. So from here you are basically expecting that the tip of that particular nasogastric tube is going to reach to the stomach, but has it actually reached to the stomach or not? How are you going to confirm this? Okay, so can you please help me with this? You're going to confirm it X-ray. Okay, so yes, X-ray is one of the options. What else is there? Okay, so why X-ray? How X-ray is going to help? Because in this particular nasogastric tube, what you need to understand is there is a, this is, I hope you're able to appreciate that this is what is a radio opaque line. Are you able to appreciate this particular clean colored line? This is a radio opaque line. Okay, so Shanky is basically saying that, you know what, let's get an X-ray done. That is what is going to tell us that, you know what, whether the tip of that particular nasogastric tube has reached to the stomach or not. Well, it can be done, but it is not the best. Okay, it's not the best one. Okay, so what else you can do? Okay, aspirate, yes. Okay, after aspirating, what? Okay, so nobody is thinking that, you know what, we can push the air from here and we can auscultate the gurgling sound. Yes, absolutely right. So another options which we have is auscultation of the gurgling sound, auscultation of the gurgling sound when you basically push the air through this particular nasogastric tube. But again, that is not the best one. Okay, so yes, this can be done, but this is again not the best one. So please understand, the best test is you have to aspirate and you have to check for the pH. Okay, so if at all the pH is acidic, because what you want it to reach to the gastric, right? In the gastric there should be gastric secretions. So when you aspirate the secretions and you check for the pH of this, it should be acidic. Okay, you understand my point? So this has been asked to you very, very recently in your FMGE exam. So please try to understand over here. The best method to check the position of the nasogastric tube is aspiration, and you basically look for the pH, okay, or pH of that particular secretion. If at all the pH of that particular secretion is acidic, yeah, that is what is kind of confirmation that your nasogastric tube has basically reached to the stomach. Yes, air push and the auscultation, that's fine, but that is not the best one, okay. So I hope you have understood, Iqbal. Okay, air push and auscultation is okay, but that is not the best one, okay. So I hope you have understood this point, okay. Now, what is the flow rate of the IV cannula, which has been shown in this particular thing? Okay, so first of all, what is this? This is what is a green IV cannula. So if I ask you the size of this particular IV cannula, what is it? Is it like the 14 gauge, 16 gauge, 18 gauge, 20 gauge, 22 gauge? What exactly is this? Okay, so the green IV cannula is basically your 16 gauge. Really? God bless me? No, it is basically 18 gauge cannula. Okay, so what is this? This is an 18 gauge cannula. And what is the flow rate of this particular 18 gauge cannula? Yes, it is. Yeah, it is 90 ml per minute. Okay, so what is the flow rate? Flow rate is basically 90 ml per minute. Okay, Shubham, it's not 16 gauge, it is 18 gauge cannula. Okay, it's an 18 gauge cannula. So let's kind of go through this particular figure. This is what is going to help you in understanding that what is the size and what is the flow rate. You have to kind of remember that. Okay, so the important ones which you have to remember are, yes, green is something which you should remember. Green, pink, blue, yellow, and maybe gray. These are the things which you have to remember. So what is a gray? Gray is basically 16 gauge cannula. We do not use it nowadays. Green cannula is the 18 gauge cannula. So if I ask you what is the IV cannula, what is the most commonly, or what is the preferred IV cannula used in the patients after the trauma? Okay, in the trauma patients, what is the preferred IV cannula which is basically used? So please try to understand. The answer over here is 18 gauge. Okay, so 18 gauge cannula is the preferred IV cannula which is used in these particular patients. Okay, please understand, it's not the orange. Okay, it is, according to the ATLS, now they basically prefer the green one. Okay, so they prefer the green one. It is not the orange. Orange so never tha. It was the gray which was used. But what you need to understand, according to ATL, it is the green one now. Okay, so please remember this. Okay, so the green one, this is what is the 18 gauge, and this has the flow rate of 90 ml per minute. Then you have the pink one, that is 20 gauge. It has a flow rate of 60 ml per minute. The blue one is basically 22 gauge. It is 36 ml per minute. And the yellow one, which is basically used in the pediatric age group, 24 gauge, the rate is basically 20 ml per minute. And the gray one, which we do not use nowadays that much, the size is 16 gauge, and here the flow rate is 180 ml per minute. Okay, so please at least remember these important ones. Okay, so please remember these important ones at least. Okay, I hope you have understood. Okay, now let's move on to this particular question. What is the diagnosis in this particular patient? Okay, so you are able to see something over here. Okay, so what is the diagnosis of this particular patient? Is it like the ureteric stricture, ureterocele, bladder stone, or the ureter calculi? So what do you think? What is the diagnosis over here, guys? Okay, so what are you basically seeing over here? It is not the ureteric stricture, guys. It is basically a ureterocele. Okay, this is a ureterocele. So what is a ureterocele? What do you understand by ureterocele? In the ureterocele, what is going to happen? In the ureterocele, the terminal portion of the ureter is dilated. Okay, and sometimes it is obstructive. Okay, so the terminal portion of the ureter is basically dilated, and sometimes it is obstructive. Okay, so because of this, the patients have hydronephrosis. Okay, because of this, the patients are going to have hydronephrosis. In the ureterocele, the terminal portion of the ureter, which is basically opening into the urinary bladder, this is basically dilated and obstructive, and because of this, the patients are having hydronephrosis. And on the intravenous pyelogram, which has been shown to you over here, what is this? This is what is an IVP, intravenous pyelogram. So on the intravenous pyelogram, the characteristic thing which you basically see in these particular patients is something which is called as an adder head appearance, or a cobra head appearance. Okay, adder head or an cobra head appearance. This is what you basically find in these particular patients. Okay, so adder head or the cobra head appearance is what you basically find in the patients with the ureterocele on the intravenous pyelogram. Okay, I hope you are able to understand this. These all are the important points about the ureterocele which you need to understand. Okay, now which of the following Okay, what is the advice given to this particular patient? Okay, so first of all, tell me the diagnosis. Okay, so this is a plain X-ray which I'm trying to show you. What is the diagnosis of this particular patient? Then we will talk about what advice you're going to give. First, tell me the diagnosis. What is the diagnosis of this particular patient? Okay, so is that a TB? No, it is not a TB. Very nice. Okay, so Kumar Udyan is basically telling us, yes, it is a gallbladder calcification or the porcelain gallbladder. Very nice. Okay, so what is the diagnosis over here? This is what is called as a porcelain gallbladder. Okay, so gallbladder. Okay, so what is this particular porcelain gallbladder? Porcelain gallbladder is basically calcified a gallbladder. Okay, so this is a calcified gallbladder. So if at all, let's say there is some person who is basically coming to you with a diagnosis of a porcelain gallbladder, what advice you're going to give to these particular patients? Okay, so the advice which you're going to give these particular patients is a cholecystectomy. Okay, so please understand this. We are going to advise these particular patients cholecystectomy. So if I ask you that what are the indications of prophylactic cholecystectomy. Okay, so if I ask you what are the indications of a prophylactic cholecystectomy, can you please help me with this? Okay, what are the indications of a prophylactic cholecystectomy? The first one is that if at all the gallstone is more than 2.5 centimeters in size. Okay, so if at all the patients are having the gallstones which are more than 2.5 centimeters in size, or let's say if at all there is a patient who is having a porcelain gallbladder, if at all there is a patient who is having a gallbladder polyp with the stone. Okay, so gallbladder polyp with the stone, or let's say if at all the patient who is having a typhoid carrier. Okay, so all these are the indications of your prophylactic cholecystectomy. Why? Because these all are the risk factor for the development of a gallbladder carcinoma. Okay, so if at all there is a patient who is having a porcelain gallbladder, you will advise that particular patient to undergo a prophylactic cholecystectomy. Why? Because that is what is a risk factor for the development of your gallbladder carcinoma. Okay, so the porcelain gallbladder, this is what is a risk factor for the development of your gallbladder carcinoma. Okay, so this is what is a risk factor for the development of your gallbladder carcinoma. I hope you have understood this particular point, guys. Okay. Right, now let's talk about the next question. Okay, so a patient after the head injury, so there's a patient who suffered with an head injury and has been brought to the hospital. The CT scan of the patient was done and we got the following image. What is the diagnosis of this particular patient? So now this particular, what you call as this history is a bit incomplete. I'll just re-elaborate the history. Frankly, the history is not accurate. Okay, the history is not accurate. So here, ideally what they should have given that there was a history of a trauma which had happened 3 weeks back. Now after that, there was a gradual deterioration in the consciousness of the patient, and now you did a CT scan, you found this particular image, and yes, the diagnosis over here is definitely your chronic SDH. Okay, why this is a chronic SDH? Because try to understand over here. Here you are having this concavo-convex kind of a lesion. Okay, so what do you have? You have a concavo-convex kind of a lesion, but at the same time, what you need to understand is that this particular portion is not that wide. Okay, it is not that wide. As I've always told you that what is an investigation of choice for a chronic SDH? Okay, what is an investigation of choice for the chronic SDH? Okay, so the investigation of choice for the chronic SDH is an MRI. Okay, investigation of choice for the chronic SDH is an MRI. Why? Because as I told you that the trauma had happened let's say 3 weeks back. So in the last 3 weeks, what has happened is that the what you call as a paramagnetic property of that particular blood has basically gone down. So now what you need to understand is that on the non-contrast CT scan, that particular lesion is not going to appear very, very wide, and sometimes it might be difficult for you to distinguish this from the normal parenchyma, and that is the reason why the investigation of choice for the chronic SDH is an MRI, and over here the diagnosis is definitely chronic SDH. Am I making some sense to you guys? Yeah, I hope I'm making some sense to you guys. Okay, so yes, okay, got it? Okay, got it. Right. Now, what you need to understand over here, other things, what you need to understand over here is that, okay, so what are the other things which you need to, okay. Now, if at all, let's say there is a patient with an EDH, okay, so if at all there is a patient with an extradural hematoma, okay, if at all there is a patient with an extradural hematoma, acute कब होगा? Okay, I'll talk to you about that. Okay, Bansal, just give me a minute. In the extradural hematoma, what you basically find is, you basically find a biconvex opacity. Okay, biconvex opacity. This basically appears very, very white. Okay, so this basically appears very, very white. If we talk about the subdural hemorrhage, okay, subdural hemorrhage. So if at all there is an acute subdural hemorrhage, you are going to have a concavo convex, or whatever the crescent or banana shaped opacity. Banana shaped opacity. Okay, so please try to understand, in from the acute versus chronic, the shape is not going to change. It is just the what opacity is basically going to change. Okay, you understand my point? Why is that in the non-contrast CT scan you find that the EDH is basically appearing white? Okay, the reason is because the acute extravasated blood is basically appearing white. Okay, because the acute extravasated blood is white, and that is the main reason why we perform a non-contrast CT scan. Are you understanding my point? So even if you perform a non-contrast CT scan in the patients with a chronic SDH, you might be able to reach to a diagnosis. But there is also a chance that you would have missed it, right? Are you able to appreciate it? If you just look at this particular portion, okay, you are not able to distinguish the normal parenchyma from the lesion in a very, very good manner, right? Are you understanding my point? Not, at least not as you would have been done in the acute kind of a condition. Okay, so that is why in the patients with the chronic SDH, the investigation of choice is your MRI. And over here, what you need to understand, in the SDH, you have a concavo convex opacity. So even in the chronic SDH, when you perform an MRI, you are going to have this banana shaped or a concavo convex opacity only, but it is going to kind of give you the diagnosis in a much easier manner, because the non-contrast CT scan has a chance of missing the diagnosis. Okay, right? Understood? So God bless me, what you need to understand, if you are suspecting the patients to have suffering from a chronic SDH, you will not perform in CT scan, you will rather perform an MRI. Okay, so that is what you need to understand over here. Okay, density of the brain hemorrhage on the CT reduces with time. Yes, absolutely right. Okay, so Dr. Iqbal has kind of mentioned that in the chronic SDH, the density, it's rather not the density, the opacity of the brain hemorrhage on the CTs, on the non-contrast CT scan, reduces with the time. Okay, right? Okay, right. Okay, great. Now, what is the sign which has been shown over here? Is it like the Cullen signs, Gray Turner sign, or the Fox sign? So, yeah, Shanky has basically told us that it is a Fox sign. So, yes, it is a Fox sign. Okay, Tripti, please understand, this is what is a Fox sign. Now, what are these particular signs? These are the signs of your acute pancreatitis. Okay, so acute hemorrhagic pancreatitis. Okay, so if at all there is a patient which are having an acute hemorrhagic pancreatitis, in these particular patients, what you can find, you can basically find what you call as a Cullen's sign. Okay, so there's something which is called as a Cullen's sign. What is this Cullen's sign? Cullen's sign is basically bluish discoloration around the umbilicus. Okay, what is this? This is what is the bluish discoloration around the umbilicus. Okay, around the umbilicus. What about the Gray Turner sign? What about the Gray Turner sign? In the Gray Turner sign, what you basically find is, in the Gray Turner sign, so in the Gray Turner sign, what you basically find is that there is a bluish discoloration in the flank region. Okay, in the flank region. Okay, so that is what is your gray Turner sign. And then finally what we have is we have a Fox sign. So what is this particular Fox sign? So in the Fox sign, it is not present in every individual's case. Okay, so all these particular signs which we're trying to talk about, it is not like that in every patient with the acute hemorrhagic pancreatitis we are going to have that. But no, sometimes you might have these particular stuff. Okay, so yeah, ecchymosis is a bluish discoloration, whatever you want to call it. So there is a bluish discoloration in the inguinal region. Okay, in the inguinal region. So what happens is that pancreas is basically the retroperitoneal structure, and if at all there is a hemorrhage which is occurring around the pancreas, that hemorrhagic kind of a fluid, it basically trickles down along the facial planes, and then we get this particular discoloration in the different parts like the Cullen sign, in the gray Turner sign, and the Fox sign. You appreciate this particular stuff, guys? Okay, so yeah, this is what you need to understand about these particular things. Okay, got it? Acute hemorrhagic pancreatitis, Cullen sign, gray Turner sign, and the Fox sign. Okay, sir, in the duplication of the ureter, where does the extra ureter opens? Okay, yeah, we will do that. We have a question on that. We will talk about that. Okay, so just give me a minute. We will talk about that. Okay, right now. Okay, so let's not break the flow. When the question comes, I'll definitely cover that for now. Okay, right now, a patient came with an abdominal pain and you suspect that there is a liver lesion on the ultrasound. You ordered an MRI which showed the following image. Which of the following is the diagnosis of this particular patient? Is it like the hepatic adenoma, hemangioma, hepatocellular carcinoma, or the focal nodal hyperplasia? So what is the, okay, so what I'll do is I'll just get out of the way so that you're able to look at this particular image in a better manner. Okay, so what you need to understand, what is the what do you call as what is the diagnosis of this particular patient? Okay, so I will kind of enlarge on this particular kind of a thing. Okay, so yes, it is hemangioma, guys. Okay, very right, very right. Okay, anybody can tell me what is the investigation which you're saying over here? What is the investigation which you're saying over here? Okay, so yes, it is a T2 weighted MRI. Okay, so what is this? This is what is a T2 weighted MRI, and what are you basically seeing over here? Hemangioma. What is this particular sign known as? Okay, what is this particular sign known as? This is, have you ever heard of the light bulb appearance? Okay, so have you ever heard of the light bulb appearance? Light bulb appearance in the patients with the hemangioma. So this is what is your light bulb appearance. Okay, LIGHT, light bulb appearance. So it appears like somebody has kind of lightened this particular bulb in the entire kind of a black surrounding. Okay, so that is what you need to understand. In the MRI everything appears black, but the hemangioma basically appears white. So this is what is your light bulb sign which you basically find in the patients with the hemangioma. Okay, now if I ask you, how are you going to manage the patients of an hemangioma? So what is the treatment of choice for the patients of hemangioma? Can you please help me with this particular question answer, guys? Okay, so what is the treatment of choice in the patients with the hemangioma? Okay, come on, guys. Yeah, what is the answer over here? What is the treatment of choice for the patients with the hemangioma? So the treatment of choice for the patients with the hemangioma is enucleation. Okay, enucleation. Most of these particular hemangiomas are asymptomatic, and the treatment of choice over here is enucleation. Okay, so what is the treatment of choice over here? The treatment of choice over here is an enucleation. Okay, enucleation is the treatment of choice in the patients with the hemangioma. Okay, now what is the diagnosis of this particular patient? Okay, so just look at this particular cystogram. Okay, what is this? This is a cystogram which you're basically looking at, and yeah, what is the diagnosis of this particular patient? Is it like a urothelial carcinoma, extraparietal bladder rupture, intraparietal bladder rupture, or the ureteral injury? Okay, so I'll just kind of come back to you on the image. So what is the diagnosis? Is it like an urothelial carcinoma, extraparietal bladder rupture, intraparietal bladder rupture, the ureteral injury? Okay, so somebody is trying to say, so Kumar is basically trying to say it's B. Everybody agree with this? Okay, so well, yes, absolutely right. Okay, what is the answer over here? It is an extraperitoneal bladder rupture. Okay, it's not BC, it is extraperitoneal bladder rupture. Okay, I hope you're able to understand. It's not an intraperitoneal bladder rupture. So first of all, what is this investigation which you're seeing over here? So this is what is a cystogram. Okay, what is this? This is a cystogram. Okay, so you have basically filled the dye inside the whatever the bladder, and I hope you're able to appreciate that there is the extra, like the contrast is basically coming out from over here. So this is what is called as a flame shaped extravasation of the contrast. Okay, what is this called as? This is what is called as a flame shaped extravasation of the contrast, and this is what you basically find in the patients with an extraperitoneal bladder rupture. In the patients with an intraperitoneal bladder rupture, what you would have found that the contrast is basically leaking up, and the contrast is basically kind of surrounding the intestinal loops. Okay, so if at all there is a contrast which is surrounding the intestinal loops, that is what is an intraperitoneal bladder rupture. But if at all the contrast is basically coming out of the bladder and there is a flame-shaped extravasation of the contrast, that is what is referred to as your extraperitoneal bladder rupture. Yes, absolutely right. On the CT scan, what you basically get is a molar tooth sign. Okay, so the molar tooth sign is basically found on the CT scan in these particular patients. Okay, very, very important. Okay, molar tooth sign is basically found on the CT scan in these particular patients. Okay, got it? Now, what is the if at all this particular patient is a male? Okay, so what I'm trying to tell you that this is a IVP of a patient, or so basically CT IVP of a patient, and what you need to understand, I'm telling you that this is what is a male patient. Okay, this is what is a male patient. So what is going to be the presentation of this particular patient? Is it going to be the incontinence? Is it going to be the urinary tract infection, acute urinary retention, or none of the above? What is the answer over here? Can you please help me with this? Okay, so what is the answer going to be over here? Acute urinary retention. Really, guys? Okay, acute urinary retention. Why acute urinary retention? We are talking about the duplication of the ureter. So so first of all, what is the diagnosis over here? It's not C, guys. Okay, it is not C. So what is the diagnosis over here? The diagnosis over here is a duplication of the ureter. So what I'm essentially trying to ask you is that if at all there is a patient with a duplication of the ureter, and if at all we are dealing with a male patient, so what is going to be the presentation of this particular patient? So yes, the answer is going to be urinary tract infection. Okay, so let's talk about the duplication of the ureter, because we also have got one query over this. Okay, so what is the duplication of the ureter? The duplication of ureter basically means that normally what we have this particular kidney, and one kidney is basically drained by the one ureter. Now in the duplication of the ureter, what is going to happen? There is one kidney which is drained by the two ureters. So the lower pole of this particular kidney is drained by one ureter, and the upper pole of the kidney is drained by the another ureter. Okay, you understand my point? So the ureter which is draining the lower pole of the kidney, this is opening into the bladder, and the ureter which is draining the upper pole of the kidney is basically ectopic. Okay, so I hope you're able to understand. This is what is your duplication of the ureter. So what is the duplication of the ureter? That is, one kidney is basically drained by two ureters. Now over here, what you need to understand is that there is something which is called as a Wiegert-Mayer law. Okay, what we have a Wiegert-Mayer law over here. So what is this particular Wiegert-Mayer law? Wiegert-Mayer law basically says that if at all there is a ureter which is basically draining the upper pole, of the ureter, this is the one which is going to open distally, medially at an ectopic location, and this is the one which is going to be obstructive in nature. Okay, so the ureter which is basically draining the upper pole of the kidney is basically going to open distally, medially at an ectopic location, and this is the one which is going to be obstructive in nature. Okay, now if at all, let's say there is a ureter which is basically draining the lower pole. Okay, if at all there is a ureter which is basically draining the lower pole of the kidney, so this is what is going to open proximally, laterally, and this is the one which is going to be reflexive in nature. Okay, so this particular ureter is going to be the reflexive, and the ureter which is basically draining distally and medially, that is what is going to be obstructive. So please try to understand over here. This is what is your Wiegert-Mayer law. This is again a very, very important rule. Wiegert-Mayer law, Wiegert-Mayer rule, whatever you want to call it. So this is what is a Wiegert-Mayer law or the rule in the patients with your what you call as a duplication of the ureter. Okay, I hope you are able to. Yes, so the ureter which is basically draining the lower pole of the kidney, yes, it is associated with the VUR. Yes, you're right, absolutely right. Okay, and so VUR is not a problem, right? Some amount of the reflux is not a problem, that's okay, but the obstruction is a problem. Okay, so the ureter which is draining the upper pole of the kidney, this is basically opening medially, and that is what is a stenotic, and that is what is causing the hydronephrosis, right? So that is what is the problem. Are you understanding my point? Right? Okay, right. Okay, yeah, so I understand what you're trying to say. There's a ureterocele. So if you read what you call as a duplication of ureter in a proper manner, so what you need to understand is the ureter which is draining the upper pole of the kidney. This is associated with the ureterocele in 80% of the patients. Okay, so yes, you rightly pointed out that this is what is a ureterocele, and this is what is associated with the ureter of the which is draining the upper pole of the kidney. Okay, right? Okay, now I'm coming to that. Okay, so now let's talk about the presentation. Okay, so what is the most common presentation of these particular patients in males and the females? Okay, so let's talk about the presentation. Okay, so the most common presentation of the duplication of the ureter in the females. Okay, so first let's talk about the females. In the females, what is going to be the most common presentation? The females will give you a characteristic history that there is a continuous dribbling of the urine, but the patient also passes normal urine. Okay, in other words, what you need to understand is that in the females, the patients are going to come to you with a urinary incontinence. Okay, urinary incontinence is going to be present in the females. Okay, so the females are basically going to come to you with a urinary incontinence. Are you able to understand this particular point? So the females are the ones which are basically going to come to you with a urinary incontinence. If we talk about the males over here, okay, so males are the one which are going to come to you with a urinary tract infection. So all you need to understand is in the males, they are never incontinent. Okay, so they're never incontinent, and they are going to present with a urinary tract infection. So most common presentation in the males is urinary tract infection. On the other hand, the most common presentation in the females is your urinary incontinence. Am I making some sense to you guys? Yeah, I hope I'm making some sense to you guys. So this is very important thing which you need to understand over here. Okay, I hope you have understood. So this is important: duplication of the ureter, Weigert-Mayer law, and the most common presentation. Why not UTI in the females? Okay, because in the females, the ectopic ureter is basically opening into the vestibule or the vagina. And because it is basically opening into the vestibule or the vagina, it is basically opening beyond the sphincter. And that is why the control of the urine is not there, and the patients basically come to you with the incontinence. So I'm not trying to say that in the females UTI is not going to happen, but every female with an ectopic ureter is going to have every female with an ectopic ureter is going to have what you call as an incontinence. UTI may happen, that's fine, but I'm talking about the most common presentation. So most common presentation is basically going to be your incontinence in the females, and the most common presentation is going to be the UTI in the males. Okay, right? I hope you're able to understand this particular point. Yes, so that's all okay. Okay, got it? Right. Now, let's talk about this. So what is the manure which is shown in this particular image? So we are trying to show some surgical manure. So what is this surgical manure which is shown in this particular image? Can you please help me with this? Is it like the cattle branch manure, Metox manure, Cocker's manure, or the none of the above? Vinay, I'll get back to you. Just give me a minute, I'll get back to you. Okay, right. So over here, what you need to understand, the answer over here is definitely a cattle branch manure. But before we move ahead, let us kind of solve it out of Vinay. So Vinay is basically trying to ask, sir, the lower O1 opens trigone. Okay, so try to understand that we are talking about the ectopic ureter. Normal ureter is going to open at the normal level in both the scenarios. Okay, so basically the ureter which is draining the lower pole of the kidney, it is broadly going to open into the bladder. So what we are concerned about is an ectopic ureter. So the ectopic ureter in the females is going to open into the vestibule or the vagina, but the ectopic ureter in the males is going to open into the, it can open at any places. Okay, so it can open into the bladder neck, it can open into the prostatic urethra, it can open into the seminal vesicle. But what you need to understand is it is never ever going to open beyond the external urethral sphincter. It is always going to be proximal to the external urethral sphincter, and that is why in the males they are never ever incontinent. Are you understand my point? So the most common location of an ectopic ureter in the males is the prostatic urethra. The most common location of an ectopic ureter in the females is the vestibule of the vagina, and that is why the females are incontinent and the males are always continent, because the ectopic ureter is going to open always proximal to the external urethral sphincter. Okay, I'm making some sense to you guys. Okay, right? I hope you understood, Vinay, right? I hope you got your doubt cleared. Okay, got it. Now let's move on over here. So what is this? This is what is a cattle brush manure. Okay, so let's say when you are trying to operate on the retroperitoneum. So let's assume that you want to operate on, let's say, this particular right kidney, or let's say you want to operate on this particular IVC. Okay, so you want to operate on this particular IVC. So what you have to do is you have to rotate the viscera medially. Otherwise, how are you going to reach to the retroperitoneum, right? Because when you open into the abdomen, what you're basically having is you are having this particular colon, you're having this particular intestine. So if you want to reach to the retroperitoneum, you cannot cut through the intestine, right? You will have to medially rotate this particular viscera. And how do you kind of do that? So this is what is your white line of told. Okay, so this is an avascular plane. So you basically put an incision in this particular avascular plane, and then you keep on dissecting, and then you medially rotate the viscera. Okay, so you medially rotate the viscera. So there are two manures which are associated with this. So one is the cattle brush manure. So what is this particular cattle brush manure? This is what is a right medial visceral rotation. Okay, right medial visceral rotation of the gut. And if at all you do the same thing on the left side, so that is what is your metox manure, medox, or whatever you want to call it. So this is what is your left medial visceral rotation of the gut. Okay, so this is what is the left medial visceral rotation of the gut. Okay, yep, got it. So these are the two important manures which you need to understand whenever you are trying to operate on the patients on the retroperitoneum. Okay, so I hope you have understood this point. Now let's move on to the next question. What is the diagnosis of this particular patient? Is it like the priapism, Peyronie's disease, penile fracture, or the urethral injury? So what is the diagnosis of this particular patient? Okay, so what are you having in this particular patient is, okay, Priyanka, I'll talk to you about the coccus. Just give me a minute. So yes, the answer over here is a Peyronie's disease. So what is this? This is basically your penile curvature. Okay, so this is what is your penile curvature, and that is what is your, the diagnosis is your Peyronie's disease. Okay, so I'll just answer about the Priyanka. Okay, so what you need to understand, Priyanka, coccus manure is basically something which you basically perform during the Whipple's procedure. Okay, during the Whipple's surgery, what you basically perform is this coccus manure. So what is this particular coccus manure? So here what you do is you basically medially rotate the duodenum because you want to reach to the pancreas, right? So in the coccerization, what you basically do is that you rotate the duodenum and the pancreas along with that. Okay, so you, like, are you understanding? So if you extend this, okay, so if you extend this particular white line of told above, okay, so over here what is going to happen, there's going to be the duodenum, and if you medially rotate the duodenum as well along with the pancreas, this is what is a coccus manure. Did you understand this particular, Priyanka? Right? So coccus, all you need to understand is coccerization or the coccus manure is something which you basically perform during the Whipple's procedure. Okay, right. So what is this? This is what is the Peyronie's disease. What is this particular Peyronie's disease? This is what is the penile curvature. This is an acquired curvature. Okay, this is an acquired curvature which usually is like there are the various reasons why these particular things happen, but probably it is because of the recurrent wear and tear, or the recurrent, basically what you call as a injury to the plaques. Okay, so recurrent injury to these particular plaques. Because of this, what you need to understand is that the penile curvature is basically happening. Okay, so yes, okay, so this is what is the penile curvature. The surgery, there are various surgeries which you can basically do. You can simply go ahead with the plication, you can go ahead with the excision of that particular plaque and the graft repair and all this particular stuff. But yes, then this Nesbitt's procedure is one of the procedures which you basically perform in these particular patients. Okay, so Nesbitt's procedure is one of the procedures which you basically perform in these particular patients of the Peyronie's disease. Okay, so I hope you have understood this point. Okay, now let's talk about this. What is the diagnosis of this particular patient? Okay, so what is the diagnosis of this particular patient? Okay, frankly, the options of this particular thing are wrong. Okay, so it should be duplication of the ureter with non-functioning upper pole. Okay, non-functioning upper pole. So this can be the answer. Okay, so this is actually the answer. So what is the answer over here? Duplication of the ureter with a non-functioning upper pole. So what you need to understand over here, that here the upper pole of the kidney is not functioning. Now what you have performed in these particular patients is an IVP, intravenous pyelography has been performed. So the upper pole of the kidney is non-functioning, so it is not going to take up the dye, but the lower pole of the kidney is functioning, so it has taken up the dye. And what it appears like, this basically appears like a drooping water lily sign. Okay, what is it appearing like? It is basically appearing like a, so on the intravenous pyelography, what are you basically going to find? You're going to find the drooping water lily sign, drooping water lily sign. Okay, you understand my point? So what you're basically finding is a drooping water lily sign in these particular patients. Okay, so yes, water lily sign is basically present in what you call as a hydrated, and the drooping water lily sign is basically present in the duplication of the ureter with a non-functioning upper pole. Okay, now before I move ahead, I'll just kind of address one particular question. So is this particular session for the NEET? Yes, obviously. See guys, what you need to understand is that the preparation for your NEET and FMG is not very different. The only difference is that in the FMG, all they have to kind of achieve is just the 50% mark. But in the NEET, you have to compete amongst yourselves and you have to kind of get the highest number of marks, because you know, like your ranking is basically decided by the relative marking. Are you understanding my point? On the other hand, the FMG, all they need to reach is the 50%. That is the only difference. The preparation is 80, 85, 90% the same. Okay, so yes, this particular session is definitely going to be helpful for the FMG as well as for the NEET and even for the I9, right? Are you understanding? The concepts are going to be the same. Are you understanding? It is just the method in which they're going to ask is a bit different. And also, obviously, the few new topics are being added and like the difficulty level of the few topics are going to change, but the 85, 90% of the papers are going to be from the similar topics. You take it I9 CET, you take it NEET PG, you take it FMG, any particular exam you kind of take it, the 80 to 90% of the topics are going to be exactly the same. Okay, so I hope I have answered your question, Ram. Sai Ram Vikas. Yeah, I hope you have understood this point. Okay, so yes, this is definitely going to help you even if you're preparing for the NEET or FMG, whatever. Okay, right. So what is the absorption time of this particular suture? Okay, so what is the absorption time of this particular suture? Okay, so what are you looking over here? This is what is a PDS suture. Okay, so this is what is a PDS suture. If I ask you what is an absorption time of this particular suture? Okay, yes, it is 180 days. Okay, so it is a 180 days. Okay, so this is what is a delayed absorbable suture. Okay, what is this? This is a delayed absorbable suture, and the answer to this particular question is a 180 days. So the tensile strength is basically lost within 90 days, but the absorption time of this particular PDS is 180 days. Okay, so please try to understand over here. Okay, so what are you dealing with over here? This is what is a PDS. Okay, so this is what is a PDS suture. So this is what is basically a delayed absorbable suture, and here the absorption time is basically 180 days. Okay, now let us talk a bit more about the, let's say, vicryl. Okay, so vicryl and monocryl, both of these are again the absorbable sutures. The only difference is that the vicryl is a multi-filament suture and the monocryl is a monofilament suture. Okay, so monocryl is a monofilament suture, vicryl is a multifilament suture. So what you need to understand over here that yeah, this is a monofilament, this is a multifilament, all those is fine, but what about the absorption time? Okay, so the absorption time of these two particular sutures is 60 to 90 days. Okay, so please try to understand over here the absorption time of the vicryl and the monocryl is 60 to 90 days. Okay, I hope you are able to appreciate these particular things, right? Okay, got it. Now what are these? These are the synthetic absorbable sutures. Okay, what are these? These are the synthetic absorbable sutures. So if I ask you about the absorbable sutures, okay, if we talk about the absorbable sutures, okay, so we have another kind of question on this, so we will talk about that. Okay, I have another question in this particular series only. I have another question and I'll cover this particular concept over there, so just give me a minute. Okay, so yeah, let's talk about this. Okay, so what is the drain? Which drain has been shown in this particular image? Okay, so what is this particular drain? Is it like a Malicord JP drain, okay, Jackson Pratt drain, or the Rumovac drain, or the ICD? What exactly is this particular thing? Okay, so can you please help me with this? Okay, yeah, so Mahi Kaushik, I have one question on the candidate. We'll talk about that. Okay, we'll talk about that. Okay, so this is not the Rumovac drain. This is not the Rumovac drain. This is what is a Jackson Pratt drain. Now this is a repeat question, guys. Okay, this was asked in your one NEET PG exam. So this is what is a JP drain. This is what is called as a Jackson Pratt drain. Okay, so what is this? This is what is a Jackson Pratt drain. So it is again it is again a kind of a negative suction drain. The only difference is that the suction which is created over here is a bit lesser, and the volume of this particular drain is also a bit lesser as compared to that of the Rumovac drain. Okay, so here the patient was subjected to, let's say, a gynecomastia surgery, and after the surgery what they had put was a Jackson-Pratt drain. Okay, I hope you have understood this particular point. Now, which of the following things about this particular patient is false? Okay, so first of all, what is the diagnosis of this particular patient? Is it like a, okay, so what is the diagnosis? It's pretty simple. I'm pretty sure that you guys might be knowing this. So this is what is your hypertrophic scar. Okay, so which of the following about the hypertrophic scar is false? It gets better with time even if not treated. It is familial. It can occur 2 weeks after the surgery. It is having a collagen type 3. Okay, so what is the answer over here? Yes, the answer is B. It is not familial, guys. Okay, it is not familial. The keloid. Keloid is something which is basically slightly associated with the familial association. But yes, I'm pretty sure that you understand what is the hypertrophic scar. Hypertrophic scar is basically a malformed scar which is basically well within the boundary. That is what is a hypertrophic scar. Keloid is a malformed scar where the scar is basically going beyond the boundaries of that particular scar. Okay, so that is what is a keloid and the hypertrophic scar. Here, what you need to understand, the diagnosis over here is a hypertrophic scar. Okay, what is the diagnosis over here? It is a hypertrophic scar. Okay, what is the diagnosis? It is a hypertrophic scar. Okay, guys. Okay, so yeah, this is what is a hypertrophic scar. Now, what is the frequency at which the tip of this particular instrument vibrates? So first of all, what is this particular instrument? So this is what is your harmonic. Okay, so this is what is your harmonic. Okay, so what is the vibration speed of the tip of this particular instrument? Okay, so first of all, tell me, how does this harmonic works? Okay, how does the harmonic works? Harmonic works on the principle of an ultrasound. Okay, so like in like the tip of that particular instrument vibrates very, very fast, and because of this, it is able to kind of attain whatever the what do you call as because of the intense vibrations, it is basically going to attain the hemostasis and all those particular stuff, right? Okay, right. Okay, I'll come back to a couple of questions which you have. Okay, right. So what is the answer over here, guys? Tell me the answer. Let's kind of go on this particular question. What is the answer? 550 hertz? No, it is a okay, got no issues. It is a 55,000 hertz. So 55k. Okay, 55,000 hertz ki frequency pe what happens? This tip of the instrument, just this tip, okay, just this particular small tip, this basically vibrates at the frequency of 55,000 hertz. Okay, and this is how it is able to kind of cut through the tissue, and at the same time it is also able to kind of attain the hemostasis. Okay, so this harmonic is basically used during the surgery. It can help you in doing the dissection of the tissue. It is helpful in the dissection of the tissue. It is also helpful in what you call attaining the hemostasis. Okay, hemostasis of the blood vessels, of the size less than 7 millimeters. Okay, so till what size you can attain the hemostasis? If at all the size of the blood vessel is less than 7 millimeters, we can attain the hemostasis with the help of this harmonic. Okay, so this is an important thing. Okay, so please try to understand this point. Okay, so this is an important thing. It is basically helpful in the dissection. It is also helpful in attaining the hemostasis. What is an advantage of this? Okay, what is an advantage of this particular harmonic? The advantage of the harmonic is that it causes very less injury to the vital structures. Okay, so let's say if at all using a monopolar cautery, so while using a monopolar cautery, you might cause injury to the nerves and the important vessels around, the big vessels or some vital structure around, right? But the harmonic, the chances of the injury are very, very less. Okay, so that is what you need to understand over here. So bleeding is less, yeah, that's fine. The bleeding and everything is kind of a bit better with that. Okay, now I had seen a couple of questions over here that yeah, so collagen, right? So like let me just see that a couple of questions were asked over here. Okay, so what? Okay, so I think which bandage? It is not a bandage, it is just what you call as a compression. So it is like a what you call as a belt. Okay, it's like a belt or a like abdominal binder. It is similar to that. Okay, so this is something which is similar to that. Why you are basically using it? Because what you need to understand is that after the surgery, the seroma formation should be kind of limited. So like in the abdomen, you apply the abdomen binder, similar kind of a bandage, binder it is there. Okay, so this is not a bandage per se. This is basically a binder kind of a thing which you're able to appreciate over here. Okay, so this is because you want to like press that particular skin onto the like underlying tissue, and that is why you're using this particular bandage, like binder kind of a thing over there. Okay, right, so that's what you need to understand over here. Okay, Everybody have had a slight idea about the harmonic scalpel. How does this particular harmonic scalpel works? That is the tip of the harmonic scalpel. It basically vibrates at a very, very high level. With this, the tissue can be cut, the tissue can be dissected, and whatever the hemostasis can be achieved, right? So yeah, that is all about the harmonic scalpel. At least remember these particular things. Up to 7mm vessels, they can be kind of hemostasized. And the advantage is that the surrounding, what you call as the vital structures, they are not going to get kind of injured with this, or the chance of the injury are very, very less if at all you're using the harmonic scalpel. Okay, now a patient who is basically chronic alcoholic came to you with the severe pain in the epigastric region. So a chronic alcoholic patient came to you with a severe pain in the epigastric region. The CT scan of the patient has been shown. What is the diagnosis of this particular patient? So this is a CT scan of the patient. Okay, so can you please help me? What is the diagnosis of this particular patient? So you should be able to appreciate the basic things in the CT scan, right? For example, what are these? These are the kidneys. Okay, so these are the kidneys. Okay, now what is this particular stuff? This is what is your pancreas, guys. Okay, what is this? This is what is a pancreas, and I hope you're able to appreciate that there are calcifications in the pancreas. Okay, so there are calcifications in the pancreas. Okay, now is it like a contrast CT or it is like a non-contrast CT? Can you please help me with this? I hope you are telling me that okay, this is a contrast CT. Why it is a contrast CT? Because as you can see over here, that the aorta is filled with the contrast, and also in the kidney, the cortex of the kidneys are having the enhancement. Are you understanding my point? So this is a contrast enhanced CT scan. And what is the diagnosis of this particular patient? Okay, so what is the diagnosis of this particular patient? The diagnosis of this particular patient is a chronic pancreatitis. Okay, so please do not mark it as an acute pancreatitis. What is the diagnosis over here? It is a chronic pancreatitis. Okay, so let's talk about a bit about acute pancreatitis and the chronic. Okay, now they can also show you this particular characteristic X-ray. Okay, so this is a very, very vivid kind of an appearance. So I hope you're able to appreciate this is what is a pancreas, and the entire pancreas is basically having the pancreatic calcification. So the pancreatic calcification is what is basically seen in the patients with your chronic pancreatitis. Okay, so pancreatic calcification is basically seen in the patients with the chronic pancreatitis. Okay, so now let's talk about your acute pancreatitis. And the acute pancreatitis, okay, so what is the most common cause of an acute pancreatitis? Can you please help me with this? What is the most common cause of an acute pancreatitis? The most common cause of an acute pancreatitis is basically your gallstone. Okay, it is gallstone. So what does this particular gallstone does? This particular gallstone causes the premature activation of enzymes. Okay, what it does is it basically causes the premature activation of an enzyme. Okay, you understand my point? So this is what the gallstone basically does. Okay, so it basically goes and it basically obstructs the common pathway of the common bile duct and the pancreatic duct, and it basically causes the premature activation of an enzyme. Okay, so that is what you need to understand. And because of this, the acute pancreatitis is a very much systemic condition. Okay, so what you need to understand over here, that there is like local pain and everything is there, local inflammation is there, and even the systemic manifestations like the ARDS, heart failure, all those particular things are associated with an acute pancreatitis. On the other hand, in the chronic pancreatitis, what is happening is that there are recurrent attacks of an acute pancreatitis. So now your pancreatic parenchyma, this has become what you call as atrophic, and there are multiple strictures and dilatation of the main pancreatic duct. So there is a multiple strictures and the dilatations of the main pancreatic duct, and there is pancreatic calcifications. Okay, pancreatic calcifications which are present in these particular patients. So this is atrophic, there are multiple strictures and the dilatations of the main pancreatic duct, and there is a pancreatic calcification which is happening in these particular patients, and that is what is the features of your what you call as a chronic pancreatitis. So whenever you get this much amount of the calcification in the pancreas, what is the diagnosis? The diagnosis is definitely a chronic pancreatitis. Okay, I hope you have understood this particular point. Okay, now I just get myself away from this particular image. So what is this particular investigation, guys? Okay, so identify the investigation shown in this particular image. What is this particular investigation? Is it like the flexible colonoscopy, capsule endoscopy, virtual colonoscopy, or a reconstructed MRI? Okay, so what is the answer over here? Can you please help me with this? Okay, so what is this? This is what is your virtual colonoscopy. Okay, so what is this? This is your virtual colonoscopy. So please try to understand. It's not a capsule endoscopy, guys. Okay. So again, I understand that this is not a very what do you call as a good question to be asked, but yeah, just trying to tell you that what is this? This is what is a virtual colonoscopy. So this is what is called as a 3D reconstructed kind of colonoscopy. So 3D reconstruction of whatever the CT scan, which is basically led to this particular virtual colonoscopy. Are you understand my point? So what is the advantage of that? What is the advantage of this particular virtual colonoscopy? The advantage is that it is non-invasive. Okay. So the advantage is it is non-invasive. What is the advantage? That this is non-invasive. Okay, but what is a disadvantage? Okay, so what is a disadvantage in these particular patients? The disadvantage is that you cannot take a biopsy. No biopsy is possible. Okay, so advantage is that it is non-invasive. The disadvantage is that is no biopsy is possible in these particular patients. Okay, virtual and the capsule through this image. Okay, so please try to understand. Capsule endoscopy doesn't looks like this. Okay, so in the capsule endoscopy, what happens is that you kind of eat in capsule, and what you basically need to understand that you get a multiple small images. Okay, so you multiple images you basically take, and the computer basically converts them into the in the capsule endoscopy, what you basically get, you get series of images. Okay, you get series of images. Okay, are you understanding my point? So that is what you need to understand over here. In the capsule endoscopy, you get the series of images, but over here, what you're able to understand, you get this. So don't you think that this is appearing like a reconstructed kind of image? So if at all you go to, so orthopedic people use this a lot. Okay, so on your CT machines, there is a like a software which can basically do this 3D reconstruction. So this is what is the 3D reconstruction. I will not be able to tell you how do you distinguish between them, but all you need to understand is once you have seen this image, now you will be able to diagnose it. Okay, you understand my point? In the capsule endoscopy, that is entirely different. Okay, in the capsule endoscopy, you get multiple images, and when you look at those particular images, image by image, this is how you basically diagnose a what you call as a that is what is the concept of your capsule endoscopy. Okay, I hope you are able to understand this particular point, guys. Okay, in pregnancy, just given. Oh no, so the peg lag and everything, that is usually not given even for any other things. Okay, so no, I mean, no, not really. So you are worried about the stool inside this? No, don't worry. You don't have to kind of give that. That's okay. Okay. So even for the surgeries nowadays, the bowel preparation is basically going out of the fashion. Okay. So even for the surgeries, you do not prefer to go ahead with the bowel preparation. As per the ERA's protocol, we usually kind of reduce the bowel. It has kind of reduced the mechanical and the pharmacological bowel preparation to a minimum now. Okay. Now, in this particular question, what you have, there is a patient who is having a gastric cancer. Which lymph node station of the neck is enlarged in this particular patient? Okay, so this is an image of the patient. Can you please help me? So I hope you're able to appreciate these are the supraclavicular group of lymph nodes. I'm telling you that these are the supraclavicular group of lymph nodes. So which lymph node station is getting enlarged? Is it like the lymph node station 6, 5, 4, or 7? Okay, so what is the lymph node station, guys? Can you please help me with this? What is the diagnosis over here? Like what lymph node station is basically enlarged in these particular patients? So yes, absolutely right. The answer is lymph node station 4. What is this? Lymph node station 4. Okay, so please try to understand what is this particular sign called as in the gastric cancer. If at all you get this supraclavicular lymph nodal enlargement, what is this particular sign known as? Okay, anybody, guys? Anybody? So this is what is called as a Trousier's sign. Okay, so what is it called as? It is called as a Trousier's sign, and this name of the lymph node is called as the Virchow's node. Okay, so please try to understand over here supraclavicular lymph node enlargement in the patients with the gastric carcinoma. What you basically get is something which is called as a Trousier's sign. Okay, so what we have is a Trousier's sign. What is this particular Trousier's sign? The Trousier's sign is basically the left supraclavicular lymph nodal enlargement. This enlarged lymph node, okay, this particular enlarged lymph node, this is what is called as a Virchow's lymph node. Okay, what is this called as? This is what is called as the Virchow's group of lymph nodes, and this is what? So this is basically the lymph node station 4. Okay, so what is this? This is what is your lymph node station 4. Please try to understand over here. So this is what is your lymph node station 4. The gastric cancer, Trozy sign, Virchow's group of lymph node station 4. Okay, I hope you have understood these particular points, guys. Okay, very, very important. Okay, now okay, so many people were saying lymph node station 6. Okay, so what is this lymph node station 6? Lymph node station 6. What is this lymph node station 6? This is what is a central group of lymph node. This is basically enlarged in what? So this is what is your sentinel lymph node for thyroid. Are you understanding my point? So in the patients with some thyroid malignancy or some thyroid kind of a problems, what you basically get is a central group of lymph node enlargement. And that is why in the patients with the medullary carcinoma of thyroid, what is the management of the patients with the medullary carcinoma of thyroid? Like in the patients with the medullary carcinoma of thyroid, what you need to understand is that we get a central group of lymph nodes. So we perform a mandatory central lymph node dissection in the patients with what you call as a medullary carcinoma of thyroid. Okay, 6th is not the para-aortic. Okay, so you are basically confusing. First of all, you are confusing a lot. So you are confusing the lymph node stations of the stomach along with the lymph node stations of the neck, and even the lymph node stations of the stomach. The 6th is not the para-aortic. Okay, it is what you call as a parapyloric. Okay, it is a parapyloric. Okay, so it is a right left parapyloric. Okay, so please try to understand, Shubham. Okay, now you guys are asking me about the lymph node stations of the neck, so I'll just quickly kind of tell you. So what we have, lymph node station 1A is basically submental group of lymph nodes. Now lymph node station 1B is basically your submandibular group of lymph nodes, mandibular group of lymph nodes. Then 2, 3 and 4 are basically your upper, middle and the lower jugular group of lymph nodes. What are these? These are the upper, middle and lower group of lymph nodes. Then we have a lymph node station 5, which is basically the lymph node of your posterior triangle lymph node. Then we have lymph node station 6, which is your central group of lymph nodes, and lymph node station 7 is your mediastinal lymph node. Okay, so it's very simple. Tomorrow morning when you are in the washroom brushing your teeth or something, you can simply revise it. Submental, submandibular, upper, middle, lower jugular. Then you have what you call as the posterior triangle, then central group of lymph nodes and the mediastinum. It takes hardly 15-30 seconds to revise the lymph node stations of the neck. Submental, submandibular, upper, middle, lower jugular, posterior triangle, central group of lymph nodes, mediastinal group of lymph nodes. Are you understanding my point? Right? Okay, I hope you're able to understand this particular point. The submental in biopsy for the breast cancer. How come? Are you kidding me? No, not really, right? No. Submental कहाँ से हो जाएगा biopsy? No, not really. Okay, I hope you're able to understand this particular point, guys. Okay, right? So, Shubham, I hope you understood what you're trying to say. So can you tell the lymph node stations of the stomach also? So please try to understand the lymph node stations of the stomach are 16 lymph node stations are there. The first 6 lymph node stations are basically associated along with the stomach. So this is the what you call as a right suprapyloric, left suprapyloric, along the rectus curvature, along the greater curvature, then right parapyloric and the left parapyloric. Okay, are you understanding? So these are the first 6 group of lymph nodes which are around the stomach. Then lymph node stations 7 to 11 are the ones which are basically surrounding the celiac vessels. Okay, so the celiac vessels. Okay, so what are these? We have the common hepatic is there, then the left gastric is there. So lymph node station 7 is your common hepatic, lymph node station 8 is your left gastric. Then we have the lymph node station 9, which is at the celiac trunk. Then lymph node station 10 is there at the splenic hilum, and the lymph node station 11 is basically along the splenic artery. Okay, so just go through that particular table. I've explained it to you. If you just rewind and kind of watch this, you will understand it. Okay, so this is how you divide it into D1, D2, D3 group of lymph nodes. Okay, so yes, D1, D2, D3 is D1 is basically your lymph node station 1 to 6. D2 is basically lymph node station 7 to 11. Forget about the D3. D3, even if you don't remember, it's fine, but you should know about the D1 and the D2 group of lymph nodes. That is something which is important. Okay, I hope you have understood. Right, now let's move on to the next question. A patient had ingested acid. Okay, so the patient had ingested acid 1 year back. Now the patient comes with the severe dysphagia. what should be the best conduit to replace the esophagus? Okay, so can you please help me with this? Here, the patient, the people are basically trying to give you that what you call as that there is a patient with this who had drank the acid, let's say 1 year back. Now the patient is having a complete dysphagia, and now you have to kind of perform a esophagectomy. There's no way around it. Okay, you have to kind of cut this particular esophagus and throw it off. Okay, but you have to replace it with something, right? So what is a preferred conduit for these particular patients? Can you please help me with this? What is the answer over here? Important. Okay, it is a very, very important thing. So can you please help me? What is the preferred conduit in these particular patients? Okay, what is the preferred conduit? Yeah, so you're saying B, jejunum. Yes. Okay. Yeah, I'll come back to that. I'll come back to that. Okay. So what is the answer over here? Jejunum, duodenum. Nobody has given the correct answer till now. Okay. So answer over here is the colon. Okay. Usually the most common wrong answer which I basically get is the A, that is the stomach. Yes, Iqbal. Yes, very nice. You answered stomach. Okay. So this is the most common wrong answer. So what you need to understand is that after the esophageal cancer, okay, after the esophageal cancer, if at all you have done the esophagectomy and now you want to replace that particular esophagus with something, so what is the preferred conduit over there? Stomach is the preferred conduit. That's fine. But in the patients with the acid, for example, I'm drinking this particular coffee over here. I drank it. Where did it go? It basically was in my esophagus for, let's say, 1 minute max. Okay, so whatever the transit time was there, 1 minute, whatever. But then it basically went into the stomach. Now, how long it is basically going to stay inside the stomach? For 2 hours. So please try to understand this particular fellow who had drank the acid 1 year back. That particular acid was in the esophagus for hardly, let's say, 1 minute, but it caused so much of a damage. But the same acid was inside the stomach for around 2 hours. So what don't you think that the stomach would also have become scarred and the charred, like scarring and contractures would have developed inside the stomach as well? So whenever you have a history of a acid injury in these particular patients, for the replacement of the esophagus, never ever choose stomach as an answer, because the stomach in these particular patients would have been scarred and the contracted. Okay, you understand my point? But if at all they don't give you the history of this particular acid injury, then yes, definitely the preferred conduit is basically your stomach. For example, in the patients with the gastric, like esophageal cancer, whenever you perform an esophagectomy, you replace that particular esophagus with the stomach. Okay, and here the next best conduit which we have is a colon, and which is basically the left-sided colon. So you don't take just a segment, you basically take the entire descending colon. Okay, left-sided descending colon, that is what you basically take. So jejunum and the duodenum, as somebody rightly said that okay, so Raghu has said that, you know what, duodenum is fixed. Yes, definitely. Duodenum will not be used. Jejunum can be used, but jejunum has other important roles to play, right? It is important for the absorption of various vital kind of a thing, right? So the preferred after the stomach is the colon. And if the colon is also not available to XYZ reason, then what you need to understand is that, yeah, what you call as, it is going to be your jejunum. Okay, I hope you're able to understand this point. Okay, right. Now let's move on to the next question over here. So there's a patient who was brought to the casualty when the patient basically experienced an instant loss of the erection while having the sexual intercourse, and he heard a snapping sound. Okay, what is the diagnosis of this particular patient? So here the patient was having a sexual intercourse, and during the sexual intercourse he basically heard a snapping sound, and then there was a loss of kind of erection, and now the patient has been brought to the kind of emergency. So what is the diagnosis of this particular patient? Yes, the diagnosis of this particular patient is a penile fracture. So this is a very, very characteristic history which you're basically going to get in these particular patients. During the sexual intercourse, there is a snapping sound and there's a sudden loss of erection. Now the patient has come to the emergency, right? Now, can you please tell me what is what you call as a appearance of the penis which you basically find in the patients with the penile fracture? So have you ever heard of an eggplant deformity? Okay, so eggplant deformity you basically get in the patients with a eggplant. Okay, eggplant. So what is this eggplant? This is basically the brinjal shaped kind of a penis. Okay, so what happens is, if at all the Buck's fascia is still kind of if at all the Buck's fascia has not been breached, okay, if at all the Buck's fascia has not been breached, what is going to happen? The blood is going to accumulate inside the Buck's fascia, and then it is going to appear like a eggplant deformity or this particular brinjal shaped penis. Okay, so please try to understand, these are the couple of images of your penile fracture. Okay, right. Now, this is, first of all, what is this? This is like a monopolar cautery or the bipolar cautery. What are you basically seeing on the screen? So is it like a monopolar or the bipolar cautery? So I hope that you are trying to say that what are you basically seeing is a monopolar cautery. Okay, what is this? This is a monopolar cautery. And what I'm trying to ask you is that the blue button in this particular cautery is basically responsible for what? So when you basically press this particular blue button, does it causes cutting, like it leads to the passing of the cutting current or the what you call as a coagulation current or the blend or the spray? What exactly is it? So yes, it basically causes the coagulation current. Okay, so please try to understand this is what is a monopolar cautery, and this yellow button, if at all you press this particular yellow button, what current is going to come? A cutting current is basically passing if at all you press on this yellow button. What about this blue button? If you press on this particular blue button, you basically get a coagulation current. Okay, so the coagulation basically current basically comes if at all you're going to press on this particular blue button. Now you understand my point? So these are the important things which you need to understand about the monopolar cautery. Now, what is the thing about this particular monopolar cautery? Okay, so do you require a patient plate? Okay, so what is this particular patient plate? Okay, so patient plate is basically needed, or it is required. Okay, it is required with the monopolar cautery. Okay, why it is required with the monopolar cautery? Because here they have a single electrode. Okay, they have a single electrode. So in order to complete the circuit, we require a patient plate, because the current is going to pass through the body of the patient. It is going to be taken up by the patient plate, and then it is going to go back to the cautery machine. So the kind of the loop is going to get completed only if at all you have a patient plate which is present over there. Are you understanding my point? So this monopolar cautery, it is having the single electrode, and because when you basically press on this particular electrode and blah blah blah, all those particular stuff, so the current has to be taken up by the what you call as a patient plate or the grounding plate, whatever you want to call it. In the bipolar cautery, you don't need these particular patient plates and the grounding plates and everything. You don't need the grounding plate or the patient plate in the bipolar cautery. I hope you have understood this particular point, guys. Okay, now what surgery has been shown in this particular kind of an image? Okay, now yeah, like just try to tell me what is the surgery which has been shown in this particular image. Is it like the modified radical mastectomy, radical mastectomy, breast conservative surgery, or the simple mastectomy? No, not a very important image. I mean, they might not kind of even show you this, but all I'm trying to make you understand is this is not a modified radical mastectomy. This is what is a radical mastectomy. So what you need to understand over here, again, I've taken this particular image from a internet, but what you need to understand is that it is a very like this basically tells us that how medical science has so much advanced in last 15-20 years or something like that. So this is a patient, this is a case kind of submitted at some place. What you need to understand is that over here what had happened was that they had performed a radical mastectomy. Why it's a radical mastectomy? Because I hope you're able to appreciate that there is ribs which are basically visible in this particular patient. Now probably this particular patient had a recurrence of the breast cancer on the opposite breast, and at this point of time, are you able to appreciate this? So this is the scar for the breast conservative surgery. So this is a very good kind of a description of an image which is basically trying to tell you that how much of the medical science is advanced over the period of last what you call as 10, 15, 20 years or something like that. Earlier we used to kind of do the radical mastectomy, and now we are basically shifting towards the breast conservative surgery. Okay, so that is what you need to understand. Now what about the modified radical mastectomy? Okay, so what do you basically remove in the patients with the modified radical mastectomy? In the MRM, that is a modified radical mastectomy, what you basically end up removing is you basically remove your breast tissue. Obviously you're going to remove the breast tissue, along with this you remove the lymph node stations 1 and 2. Okay, now this lymph node station 2 is basically present behind the pectoralis minor. Okay, so lymph node station 2 is basically present behind the pectoralis minor, and if at all you want to remove this particular lymph node station 2, what you need to understand, you have to do something to the pectoralis minor. So if I ask you what are the types of this modified radical mastectomy, so please try to understand. You have Auchincloss, you have Scanlon, and you have Pettis. Okay, you have Pettis. So what you basically do in the Auchincloss modified radical mastectomy, you just, okay, so let's start with the Pettis. In the Pettis, what you do is you basically remove the pectoralis minor muscle. Okay, you kind of get rid of the pectoralis minor because you want to kind of remove the lymph node station 2 as well. In the Scanlon, what you basically do is you cut the pectoralis minor But after you have kind of removed the lymph nodes, you do the reanastomosis of that. Okay, so you cut, you remove the lymph node station 2, and then you again suture that particular pectoralis minor. What about the Auchen clause? In the Auchen clause, you retract. Okay, so what you do is you retract the pectoralis minor muscle. Okay, so this is what is the Auchen clause, and the Auchen clause is one which is basically most commonly done. Okay, so this is the most commonly done in today's times. Okay, the Auchen clause is the one which is most commonly done in the today's time. Are you understanding my point? So yeah, I hope you're able to. In the radical, you remove the pectoralis major and the minor. Okay, so you in the radical mastectomy, you remove the breast tissue, that's fine, but you also remove the pectoralis major, you remove the pectoralis minor, you remove the lymph node stations 1, 2, and 3. All these particular things you remove in the radical mastectomy. The modified radical mastectomy, you basically only remove the breast tissue and you remove the lymph node station 1 and 2. Pectoralis major and minor are basically preserved in these particular patients. Okay, so pectoralis major and minor are preserved in the modified radical mastectomy. Okay, I hope you have understood this particular point. Okay, now what is the diagnosis of this particular patient? Can you please help me with this? Okay, what is the diagnosis of this particular patient? Okay, so here what you have is that there is a patient in whom you had performed, let's say, a mastectomy or anything like that, and now what you're basically saying that okay. So in this, what you're basically saying that there are nodules which are basically present on this particular lymphedema. What is this? This is what is a lymphangiosarcoma. Okay. So what is this? This is a lymphangiosarcoma which is occurring in the long-standing lymphedema. So what you need to understand is that if at all, let's say there is a patient who has been subjected to a, let's say, mastectomy. Okay, mastectomy, and after that, let's say if at all there was an aggressive lymph node dissection, or let's say the patient received a radiotherapy and all those particular things, because of this, what you need to understand, the patients are going to develop the lymphedema. Okay, lymphedema. So patients is basically going to develop lymphedema, and if at all there is a long standing lymphedema, okay, if at all there is a long standing lymphedema, so what is going to happen because of this, that the patients are basically going to have what you development of the nodules and the hemorrhage. Okay, nodules and the hemorrhage are going to develop on this particular long-standing lymphedema, and this is what is the development of your lymphangiosarcoma. Lymphangiosarcoma. Okay, so what is this lymphangiosarcoma? Lymphangiosarcoma is basically the transformation of the lymphedema into the, like after the nodules and hemorrhage are basically developing, this is what is a lymphangiosarcoma, and this is what is called as a Stewart-Travis syndrome. Okay, so what is this referred to as here? This is what is called as a Stewart-Travis syndrome. Okay, what is this called as? This is what is referred to as your Stewart-Travis syndrome. Okay, so this is what is your Stewart-Travis syndrome. Okay, now let's talk about this. Somebody is asking me about the what did you talk about? Somebody was asking about scanlon. Scanlon is basically, see, what you need to understand is that, let's say if at all this is the pectoralis minor muscle. Okay, let's say this is a pectoralis minor muscle. What you basically do is you cut the pectoralis minor. You cut the pectoralis minor. Now you remove the lymph node station 2, and what you have now, you have the two parts of the pectoralis minor. So you again suture the pectoralis minor together. Okay, you repair the pectoralis minor. This is what is a scanlon. It basically says that you cut, you remove the lymph nodes, and then you again resuture those particular the two parts of the pectoralis minor which you have just cut. Okay, in the Auchen clause, they basically say that just retract and you kind of take that particular lymph nodes out. Okay, so this is what you need to understand about the what you call as the Auchen clause and the scanlon and all those particular stuff. Okay, I hope you have understood about the modified radical mastectomy. Now, what is the diagnosis of this particular patient? Okay, what is this? Is it like the giant fibroadenomas, cystosarcoma phylloids, carcinoma of the breast, or the teratoma? Okay, so can you please help me? What is the diagnosis of this particular patient? Okay, so this is what is your phylloids tumor. Okay, so the cystosarcoma phylloids. Okay, so that is what is the diagnosis over here. So whenever you have this particular cystosarcoma phylloids, what are you going to have? You're going to have a very, very massive tumor with multiple bumps and the nodules. Like I hope you're able to understand. You will have a multiple this bumpy tumor. Okay, you're going to have a very, very bumpy tumor. So this is what is your cystosarcoma phylloids. Okay, so cystosarcoma phylloids is your bumpy tumor, and you will like, and the characteristic thing about the cystosarcoma phylloids is that this particular tumor is not fixed to the chest wall. Okay, it is not fixed to the chest wall, and over here, what is the treatment over here? It is a simple mastectomy. Okay, so what you have to perform is a simple mastectomy. Okay, so what is the management of these particular patients? Simple mastectomy. That is what is the management in these particular patients. Okay, I hope you have understood this particular point, guys. Okay, now Okay, so what investigation has been demonstrated in this particular image? Okay, so I'll just kind of enlarge this particular image. You just have a look at this. Okay, just have a look at this. I'll not, yeah. So have a look at this particular image in totality and tell me what is this particular investigation? Is it like an ERCP, MRCP, T-tube cholangiography, HIDA scan? What is the answer over here? Okay, no, it is not ERCP, it is not MRCP, guys. Come on, it's not ERCP, it's not MRCP. Come on, guys. Somebody give me the right answer. Yes, Shanky. Very nice. So what is this? This is what is a T-tube cholangiography. Are you able to appreciate this? Okay, are you able to appreciate this? This is what is a T-tube. Okay, so please try to appreciate this is what is a T-tube. Okay, so this is what is a T-tube, which you have is this is what is a T-tube. Are you understand my point? So this is what is a T-tube cholangiography. Okay, so now let's try to understand when do you perform this particular T-tube cholangiography. So let's say if at all there is a patient who is having a CBD stone, common bile duct stone. Okay, so the stone was bigger. You tried to remove it with the help of an ERCP. So what is the treatment of choice if at all there is a CBD stone? The treatment of choice is your ERCP. So you tried the ERCP, but this particular thing failed. Okay, so this particular thing failed. So what you did was you explored. Okay, so you explored the common bile duct. Okay, so what you did was you end up exploring the common bile duct. Okay, so you explored the common bile duct. Once you have explored this particular common bile duct, you are going to repair it over T-tube. Okay, so what are you going to do? You are going to repair it over the T-tube. So what you need to understand is that let's assume that this is a kidney. So this is a liver, and we have the right and the left hepatic duct. This is what is a common hepatic duct. This is what is a cystic duct. This is what is a common bile duct. Okay, now let's say if at all there was a stone over here. You open this particular common bile duct and you have kind of removed that particular stone and everything. And but now what you have going to do, you're going to put this particular T-tube over here. So this is a plastic tube which you basically put inside this particular lumen, and the longer part of this particular T-tube is like a T, right? Okay, obviously it's like a T. So the longer part basically comes out of the abdomen as a drain. Okay, so the longer part basically comes out of the abdomen as a drain, and the two ends are basically present inside the common bile duct. Why are you wanting to kind of keep that particular T-tube inside this particular common bile duct? Because you want to, for the two things, okay, for the two things. One is basically to prevent the stricture. Okay, so you really want to prevent the stricture from formation. The another one is you want to perform the T-tube cholangiography. Why? Because you want to see whether did you screw up or not. Okay, whether did you kind of leave behind some stones over there or not. Are you understanding my point? So that is the reason why you have to perform the what you call as a T-tube cholangiography in these particular patients. Okay, so yes, somebody has rightly said in the kind of comments, this T-tube cholangiography, what you need to understand is that it is basically performed on the post-operative day. So this is basically performed on the post-operative day 5 to 7. Okay, so this is basically performed on the post-operative day 5 to 7. You perform this particular T-tube cholangiography on the post-operative day 5 to 7. Okay, so usually around 7 to 8 and all this particular stuff, right? And what is the reason why you want to perform this particular T-tube cholangiography? Because you want to see whether there is any retained stone inside that particular area or not. Okay, so this is all about the T-tube cholangiography which you need to understand over here. Okay, so this is what is this investigation? This is what is a T-tube cholangiography. I hope now you have understood this particular point, guys. Okay, now there is a 1-day-old child. So patient is 1 day old. So there's a 1-day-old child with a non-bilious vomiting. What is the diagnosis of this particular patient? A non-bilious vomiting. Okay, please try to understand. What is this? Is it like a duodenal atresia, annular pancreas, ileal atresia, midgut volvulus? So what you need to understand is that, yeah, so duodenal atresia, annular pancreas, in both these particular scenarios, you are going to have the what you call as a double bubble appearance. We all understand that. Okay, so duodenal atresia, annular pancreas, both these particular scenarios, we have a double bubble appearance. But what you need to appreciate is that in the patients with the duodenal atresia, usually you get a bilious vomiting. Okay, so you usually get a bilious vomiting, and this you basically get in around 80% of the patients. So the 80% of the patients of the duodenal atresia, you have a bilious vomiting. But in the annular pancreas, you basically tend to get a non-bilious vomiting. Okay, so please try to understand this is a typical knee-jerk type of a question. In the exam, if all this particular question comes, you'll have what a simple question, but let's kind of mark it and kind of move ahead. So you will mark it at the duodenal atresia and you will move ahead. But please try to understand, if at all they have given both the duodenal atresia as well as the annular pancreas, you have to kind of keep your mind and you have to kind of read the question completely. What kind of a vomiting are they describing? If at all they are describing a bilious vomiting, then it's better to mark it as a duodenal atresia. If at all they're describing as a non-bilious vomiting, then you can mark it as a annular pancreas. Okay, so please try to understand over here. Very, very important. What is the answer? Answer is annular pancreas because they have given you the non-bilious vomiting over here. Okay, right. Now, what is the congenital swelling in these particular patients? Is it like the cystic hygroma? Is it the branchial cyst? Is it like the Zenker's diverticulum? Or is it like a lateral aberrant thyroid? Okay, so what is the diagnosis of this particular patient? Okay, so what you're basically finding in these particular patients is, yes, this is what is a branchial cyst. Okay, so what is this particular branchial cyst? This is a cystic. Okay, so this is basically a cyst. Okay, so please try to understand what is this particular branchial cyst. So branchial cyst is basically the remnant of a second pharyngeal pouch. So this is a remnant of the second pharyngeal pouch, and what you basically have is that you have this particular sternocleidomastoid muscle. Okay, so we have this particular sternocleidomastoid muscle. So over here, what you need to understand is that there is a cyst which is basically present between the upper 1/3 and the lower 2/3. Okay, so this is a cyst which you basically have between the upper 1/3 and the lower 2/3. Okay, so you have a cystic kind of a cyst is basically present between on the anterior border. So please try to understand what is the location of this particular cyst. The location of the cyst is basically on the anterior border of the sternocleidomastoid muscle between the upper 1/3 and the lower 2/3. Okay, so please try to understand, cyst is basically present on the anterior border between the upper 1/3 and the lower 2/3. Okay, please try to understand, this is a very, very characteristic description of the branchial cyst. Okay, so yeah, that is why the diagnosis over here is basically the branchial cyst. Okay, everybody have understood this particular point? Okay, now most common structure injured during the excision of this particular lesion. Okay, so first of all, what is the diagnosis of this particular patient? What is the diagnosis? So there is a swelling of the floor of the mouth. Okay, what are you basically having over here? So you have a swelling of the floor of the mouth. Okay, so what is the diagnosis of this particular patient, guys? Okay, what is the diagnosis of this particular patient? Diagnosis of this particular patient is ranular. Okay, ranular. So what is this ranular? Ranular is basically the swelling of the floor of mouth. Okay, so this is what is the swelling of the floor of the mouth. Okay, understood? So this is what is the swelling of the floor of the mouth. And if at all, okay, so what is the management of these particular patients? In the ranular, what is the management? The management is basically excision. Okay, so excision is the management of these particular patients. And when we are doing the excision of this particular ranular, the most common structure which is injured is your submandibular duct. Okay, what is the answer over here? It is A, submandibular duct. Okay, please try to understand over here. So in the surgeries of the ranula, okay, first of all, what is this ranula? Ranula, it is usually an extravasation cyst. It is an extravasation cyst of the sublingual gland. Okay, this basically presents as the swelling of the floor of mouth. Okay, so this basically presents as the swelling of the floor of the mouth. Now, whenever you have the patients of ranula, the management of this particular ranula is an excision. You have to perform an excision, and whenever you want to perform an excision, the most common structure injured is the submandibular duct, and the most common nerve injured is your, what you call as a lingual nerve. Okay, so please try to understand over here, the most common structure which is injured is your submandibular duct, and the most common nerve which is injured is basically your lingual nerve. Are you able to appreciate these particular things, guys, here? So please understand this, okay? So these all are the important points about the ranula which you need to understand. It's an extravasation cyst involving the floor of the mouth. The most common structure injured is your basically submandibular duct. Most common nerve injured is basically your lingual nerve, okay? Now, what is the investigation which has been shown in this particular image? Now, it's a very interesting question. Okay, so please try to answer. What is this particular investigation which you're seeing on this particular image? Is it like a plain X-ray, intravenous pylography, or intravenous urography, whatever you want to call it, intravenous pylography or intravenous urography, CCT or MRI? What is the answer over here? Right? B? Anybody else, guys? Anybody else? Yeah? Yes. So all of you have given me a wrong answer. Okay, so only Honeybee has given me the right answer. What is this? This is a plain X-ray KUB. So please try to understand, guys. Okay, please try to understand over here. If at all this is, let's assume that this is an IVP. Okay, if at all this is an IVP, what about the kidney? What about the renal cortex? Why the renal cortex is not having any particular dye? And what about the ureter? Like, what about the ureter? Like the distal part of the ureter? What about the opposite kidney? What about the ureter of the opposite kidney? Are you understand my point? If at all you put in a dye, it is going to be taken up by both the kidneys, right? So yes, absolutely right. This is what is a Staghorn calculus, and this is what is the simple plain X-ray KUB. Okay, so I just kind of gave you this particular question. Obviously, this particular question might not come as it is. They might give you the image. They might give you that this is an X-ray KUB. What is the diagnosis? The answer is definitely is a Staghorn calculus. But why I gave you the question like this? Because I want you to kind of have your complete attention whenever you are solving any particular question, guys. Okay, be analytical, because that is very, very important. If you have this knee-jerk responses, you will end up committing many silly mistakes, and that is something which is going to bring your rank down, or maybe might be the reason for your not getting selected in the FMG. You understand my point? So please try to understand. The investigation which is over here is an X-ray KUB. What are you basically finding over here is a Staghorn calculi. Okay, so let's talk a couple of questions about the Staghorn calculus. What is the most common organism which is associated with the Staghorn calculus? Staghorn calculus. What do you think? What is the most common organism which is associated with the Staghorn calculus? It is the Proteus. Okay, Proteus. Why Proteus? Because this has urease enzyme. Okay, it has a urease enzymes. Please try to understand. The most common organism which is associated with this is a Proteus. Okay, understood, guys? Yeah. Okay, now let's move to the next question. So what is the most common cause of death in the patients whose intrauterine scan has been shown to you? So what I am trying to show you over here, so this is what is an intrauterine ultrasound. Okay, intrauterine ultrasound of the patient. So first of all, tell me the diagnosis. Okay, what are you dealing with? Okay, so what are you dealing with over here? What is the diagnosis in these particular patients? Renal failure. Okay, really? Okay. So what is a, yeah. So the diagnosis of this particular patient is posterior urethral valve. Okay, what is the diagnosis? It is a posterior urethral valve, right? And what is this particular appearance? Okay, what is this particular characteristic appearance which you're basically getting over here? So this is what is your keyhole sign. Okay, what is this? This is what is a keyhole sign. Okay, so what is this? This is what is a keyhole sign, and this is what is your posterior urethral valve. What is the diagnosis? It is a posterior urethral valve. What are you basically seeing is a keyhole sign. And if at all there is a patient who is having a posterior urethral valve, what is the most common cause of the death? Okay, what is the most common cause of the death in these particular patients with a posterior urethral valve? The answer over here is pulmonary hypoplasia, guys. Okay, so what is going to happen if at all the in these particular posterior urethral valve, the patients are going to have oliguria. Okay, or oliguria, no, not oliguria, oligohydramnios. Okay, so what the mothers are going to have the history of oligohydramnios. Okay, so because of this, what is going to happen? The lungs of the fetus will not be able to develop in a proper manner, and because of this, the patients are going to have the pulmonary hypoplasia. Okay, so because of the oligohydramnios, the lungs are not being able to kind of develop in a proper manner, and because of this, the patients are basically having the pulmonary hypoplasia. Are you understand my point? So yeah, that is what is the most common cause of death in these particular patients. Pulmonary hypoplasia is not because of the renal failure. Okay, got it? Now, what is the management of this particular patient? Okay, so what is the management of this particular patient? So first of all, what is this? This is what is the diagnosis of this particular patient? The diagnosis of this particular patient is Fournier's gangrene. Okay, what is this? This is what is a Fournier's gangrene. Okay, so this is what is a Fournier's gangrene. So what is the management of these particular patients? If at all there is a Fournier's gangrene, what is the management of this particular patient? Obviously it is going to be the debridement, right? What about the debridement? What about the orchidectomy? Will you perform an orchidectomy in these particular patients? Will you perform an orchidectomy in these particular patients? So yes, right? So Mukesh is saying B, right? So yes, you will perform an orchidectomy, right? The answer is no, right? No, you're not going to perform the orchidectomy in these particular patients. No, not done. Okay, you will not perform an orchidectomy. So let me just ask you a couple of questions about over here. So in the patients with the Fournier's gangrene, okay, if I ask you, what is the most common organism associated with this? So please try to understand. Here there are anaerobes, okay, anaerobes. Along with that there is aerobes as well, So essentially what you have is a polymicrobial. Okay, so please try to understand over here. The in these particular patients what you have is a polymicrobial means anaerobes along with the aerobes. Okay, so that is what you need to understand. Now in these particular patients, orchidectomy is not done. Okay, why is it not done? Why will you not perform an orchidectomy in these particular patients? Orchidectomy is not done in these particular patients because the blood flow of the testes is basically coming directly from the aorta. Okay, so because the blood flow of the testes is basically directly coming from the aorta, and that is the reason why the orchidectomy is not done in these particular patients, because the testes are viable, because the blood flow is basically directly coming from the aorta. Are you understanding my point? So please understand this particular stuff. The blood flow to the testes is basically directly coming from the aorta, and that is the reason why the orchidectomy is not done in these particular patients. I hope you have understood this point. Okay, now what is the diagnosis of this particular patient? Is it like the testicular torsion, epididymal orchitis, torsion of the hydrated of Morgagni, or the epididymal cyst? Okay, so what is the diagnosis of this particular patient? Can you please help me with this? Okay, so what is the diagnosis? Is it like the testicular torsion, epididymal orchitis, torsion of the hydrated of Morgagni, or the epididymal cyst? Okay, so the answer over here is torsion of the hydrated of Morgagni. Okay, so please try to understand, this is what is a torsion of the hydrated of Morgagni, and what is the characteristic sign which you're basically getting over here? So you are basically having this blue dot sign. Okay, so what is this torsion of hydrated of Morgagni? I'll just talk to you about this. Okay, I'll just talk to you about this torsion of hydrated of Morgagni. So what you need to understand is that we have the testes and we have something which is called as an appendix of the testes. Okay, so let's assume that this is a testes. So what do we have? We have this appendix of the testes. Okay, so this is a pedunculated structure. This is an embryological remnant which is basically present on the testes. Okay, now due to some damn reason, this particular appendix of the testes can basically rotate on its own axis. Okay, so this appendix of testes, it can rotate on its own axis, and if at all this rotates on its own axis, what is going to happen? The blood supply to this particular appendage of that particular testes is going to go down, and this is going to become necrotic. Okay, so when you are basically going to stretch the skin and you are going to see this particular stuff, it is going to appear like a blue dot sign. Okay, are you able to appreciate this? So this is what is a blue dot in the surrounding of the normal skin. So this is what is referred to as your blue dot sign, which you see in the patients with the torsion of hydrated of Morgagni. So how the patients are going to come to you? The patients are going to come to you with what you call as a painful scrotal swelling. The patients are going to have a severe pain inside the scrotum. That is what the patients are going to have, and yeah, that is what is a blue dot sign. Okay, I hope you have understood this particular point. So blue dot sign, torsion of hydrated of Morgagni. What about the management? It is conservative. Okay, so management of the torsion of hydrated of Morgagni is conservative. So what you basically give these particular patients is painkillers and antibiotics and everything, and whatever the macrophages and everything are going to take care of this torsion of hydrated of Morgagni. It's a conservative management. Give painkillers, antibiotics, and that's what you basically give in these particular patients. Okay, now okay, we are at 9:35 at this point of time. Let's take a small break. Let's take a break of around, let's say, 15 minutes. We will meet back at 9:50. Okay, and we will wrap up the class by, let's say, 12:30. We'll wrap up the class. Okay, so we'll meet back at 9:50. Okay, after 15 minutes we'll meet. Okay, everybody's okay with this? Okay, so let's have a small break, and yeah, we'll meet back after 15 minutes at 9:50. Okay, at 9:50 we'll meet. Okay guys, yeah. So hi guys, welcome back, and yeah, let's start with talking about this. Okay, so let's move ahead. What we have is we have a question. What is the complication most commonly occurs on which post-operative day? So you are basically able to see this particular complication over here. Okay, so what I'm trying to ask you is that this particular complication is going to occur on which post-operative day? Okay, so yes guys, what do you think? What is the answer over here? C, 5th to 7th. Okay, so the complication is basically going to occur on the post-operative day, 5th to 7th. Yes, absolutely right. What is this? We are dealing with over here the burst abdomen. Okay, so what is this? This is what is a burst abdomen. Okay, so what happens in the patients with the burst abdomen, that is the sheath is basically giving away. Okay, so the sheath of the abdomen is basically giving away. What are the sutures you had taken on the sheath of the abdomen? That particular sheath has basically given away. So this is what is a burst abdomen, and the burst abdomen characteristically occurs on the post-operative day 5th to 7th. Okay, so I hope you are able to understand this point. What is this? This is what is the burst abdomen. And what is going to happen in this particular burst abdomen? That is the sheath of the abdomen is giving away. Okay, and if at all the sheath of the abdomen is basically giving away, what you need to understand is that yeah, this is what is the burst abdomen. That's fine. Now if I ask you, what is the surest sign? Okay, what is the surest sign of this particular burst abdomen? So this is what is basically called as a copious amount of seropurulent discharge which is coming out from that particular abdomen. Okay, so the copious, like the large amount of the seropurulent discharge which is basically coming out, serosanguinous of the seropurulent discharge, not okay, so serosanguinous discharge. Okay, that's a better word. I understand your point. It is usually not purulent. So purulent basically means infection. So yes, it is a sanguinous discharge which is basically coming out from the abdomen, and this is what is referred to as your Salmon sign. Okay, what is this? This is what is called as a Salmon sign. Okay, so the Salmon sign, copious amount of the serosanguinous discharge coming out of the abdomen, that is what is referred to as your burst abdomen, and this is what is the surest sign of the burst abdomen. Okay, I hope you have understood this particular point. Now let's move on to this. This particular catheter is used for what? So you have this particular image of this particular catheter. This is used for what? Urobag used. Okay, so Saloni, okay, so you can answer this particular question. By then I will address it out of Saloni. Saloni is saying that Urobag is used. Okay, so whenever you have a patient with a burst abdomen, what you have to do is you have to kind of remove all the sutures, and you have to kind of retake the sutures. Now you have to kind of re-explore, and you have to kind of retake the sutures. Now like the use of the Urobag or not, or rather the temporary closure or not, this basically depends whether the edges of the wound are being able to brought to each other in a easy manner. If at all you are able to bring the edges of the wound closer to each other in an easy manner, you will go ahead with the primary closure. But if at all you are not able to bring the edges towards each other in the easy manner, or rather tension is being created when you're trying to bring the edges together, then you will use a Urobag or a Bogota bag or something like that. Then you will perform a temporary closure. Okay, I hope you have understood, Saloni, right? Now over here, this is basically used for your arterial thrombosis. Okay, so what is this? This is what is a Fogarty catheter. Okay, what is this? This is what is a Fogarty catheter, which is basically used for the arterial thrombosis. Okay, so please try to understand what is this. This is a Fogarty catheter which you basically use in the patients whenever there is an arterial thrombus. If you want to remove that particular arterial thrombus, this is what you basically use it. Okay, so this is not a Urobag, guys. Okay, so I hope you're able to understand. This is not a Foley's catheter. Okay, this is a Fogarty catheter. There is a hell lot of a difference. This is not used in the urinary retention. Okay, I hope you have understood this point. Now the angiography image is basically shown to you. What is the diagnosis in this particular patient? So you are being shown the angiography image. What is the diagnosis of this particular patient? Is it like the varicose vein, peripheral vascular disease, venous thrombosis, arterial thrombosis? Okay, what is the answer over here? Varicose vein, right? Yeah, what is the answer over here? Varicose vein. Okay, venous thrombosis, right? Okay, somebody give me a correct answer. Guys, it is an arteriography image. How the hell are you answering it as a varicose vein and the venous thrombosis? The veins are not even visible in this particular image. So yes, Priyanka, this is what is your peripheral vascular disease. Okay, so what is this? This is what is a PVD, peripheral vascular disease. And what are you basically seeing in this particular stuff? So what you're able to, are you able to appreciate these corkscrew collaterals? I'll just draw it over here. So these are the corkscrew collaterals. Okay, so what you basically get in these particular patients, what you get is a corkscrew collaterals. Okay, so the corkscrew collaterals are something which you basically find in the patients of this peripheral vascular disease. Are you understand my point? So what is the diagnosis? Diagnosis is the peripheral vascular disease. What you basically find in that is a corkscrew collaterals. Are you understanding my point? Peripheral vascular disease, corkscrew collaterals, thromboinitis obliterans, Berger's disease. Okay, I hope you are able to understand this particular point. Okay, understood? Got it? Okay, right guys. Okay, so corkscrew collaterals on the arteriography, peripheral vascular disease. Okay, right. Now let's move on to this. What is the diagnosis of this particular patient? Okay, what is the diagnosis of this particular patient? Is it like the squamous cell carcinoma, basal cell carcinoma, melanoma, or none of the above? Okay, so here you have an ulcerative lesion on the lower lip. Okay, so you have an ulcerative lesion on the lower lip, and all I'm trying to ask you is that what is the diagnosis of this particular patient? Okay, so is it like the squamous cell carcinoma or the basal cell carcinoma or melanoma, none of the above? So yes guys, the answer over here is the squamous cell carcinoma. Okay, it is not the basal cell carcinoma guys. Okay, so all you need to understand is that whenever you are in a doubt, okay, so always basically draw a line between your lateral portion of the lips to the kind of the ears. So whatever the ulcers are basically occurring below this particular part, this is what is your squamous cell carcinoma. Okay, and the ulcers which are basically occurring above this particular part, these are what is the basal cell carcinoma. So basal cell carcinomas are basically present in this like this teardrop kind of a place. Okay, so where there is a rolling drop or the teardrop, these are the places where you basically find the basal cell carcinoma. Over here, this is what is your squamous cell carcinoma. Okay, I hope you're able to understand. And what type of the edges are seen in the patients with the squamous cell carcinoma? What is the type of the edge? So what you basically find is an everted edges. Okay, everted edges are basically seen in the patients with the squamous cell carcinoma. Okay, everted edges are basically seen in the patients with the squamous cell carcinoma. Okay, understood. Okay, now what is the diagnosis of this particular patient? Okay, is it like the squamous cell carcinoma, basal cell carcinoma, melanoma, or none of the above? Okay, so please understand this. Okay, so what is this? Okay, so is this like a squamous cell carcinoma, basal cell carcinoma, melanoma, or none of the above? Please put your answers, guys. What do you think? What is the answer over here? Okay, so it is not the bulla. No. Okay, yes, it is. What is the basal cell carcinoma, guys? Okay, so okay, if I ask you what type of ulcers are seen in the basal cell carcinoma? Okay, what about the edges? What about the edges of the basal cell carcinoma? What type of edges are basically seen in the basal cell carcinoma? You have talked a lot about this, like the rolled out edges. Okay, rolled out edges. But guys, we all forget that if I ask you what is the most common type of basal cell carcinoma, the most common type of the basal cell carcinoma is nodular. Are you understanding my point? So the most common type of the basal cell carcinoma is the nodular. So here what you're able to appreciate is that there is a nodule. Okay, so please try to understand what you have. We have a nodule with dilated telangiectatic vessels over it. Okay, so we have a nodule with a dilated telangiectatic. Are you able to appreciate it? So these are the telangiectatic vessels over this particular nodules. Okay, so we have a dilated telangiectatic vessels over this particular nodule. So this is what you need to understand about the basal cell carcinoma. Okay, so what is the most common type of the basal cell carcinoma? Is a nodular, and over here what you get is a nodule with a dilated telangiectatic vessels over it. Okay, so please try to remember this. Even if they don't give you the image, even if they give you this particular description that there is a nodular lesion with a dilated telangiectatic vessels over it, the diagnosis of that particular patient is a basal cell carcinoma. It's a very important, and this has been tested quite a lot of times. So please do remember this important image. Okay, now what is the diagnosis of this particular patient, guys? Okay, so over here, what is the diagnosis of this particular patient? Can you please help me with this? Yep. What is the diagnosis of the like patient over here? Okay, so yes, the diagnosis of the patient over here is a retrosternal goiter. Okay, what is this? This is what is a retrosternal goiter, and what is the sign which is being demonstrated over here? This is what is called as a Pemberton's sign. Okay, what is this? This is what is your Pemberton sign. Okay, so what we have is a Pemberton signs, which is basically seen in this particular patient. Okay, so over here, this is what is a provocative sign. Okay, what this Pemberton sign? This is what is a provocative kind of test, provocative test. So what you basically need to understand, when the patient walks to your clinic, okay, the patient is absolutely fine. Patient is sitting in front of you, patient is absolutely fine. Then what you do, you ask the patients to kind of elevate both the kind of upper limbs above the ears. Okay, so when the patient elevates both the upper hands above this particular part, what you need to understand is that the patient basically develops the facial plethora. Okay, so patient develops the venous congestion and the facial plethora, because the veins are basically getting compressed, and because of this the patient basically becomes the facial plethora. Okay, I hope you are able to understand this point. And this is what is a Pemberton sign, which is basically kind of present in the patients with the retrosternal goiter. Okay, now Saroni is asking, sir, Roos sign mein kya hota hai? So Roos sign is first of all not for this. Okay, so can anybody tell me? So first of all, you tell me, the Roos test is used for the diagnosis of what? Okay, so Saloni, can you please help me with this? The Roos test is used for the diagnosis of what? This is basically for the thoracic outlet syndrome. Okay, so what you asked, okay, so what is the another name of the Roos test? Okay, so what is the another name of this particular Roos test? Okay, so Roos test is also referred to as your East test. Okay, East. What is this East? East is extended arm stress test. Okay, so what is this? This is what is an extended arm stress test. What you basically ask the patients, you ask the patients to go into this particular position, and then you ask the patients to close and open the fist like this. So if at all the patient is having a thoracic outlet obstruction, what you need to understand, within 3 minutes the patients are going to have fatigue. So if at all the patients develop fatigue within 3 minutes, then this is diagnostic of your thoracic outlet syndrome. Okay, I hope you have understood this point, right? Got it? Now let's move on to the next question. What is the treatment of this particular disease? Okay, so first of all, you have to kind of make the diagnosis. So again, I'll get myself away from this particular screen, and now you can look at this particular image in a proper manner. Now, can you please help me? What is the diagnosis of this particular patient? First of all, tell me the diagnosis. What is the diagnosis of this patient? So please try to understand what is being demonstrated in this particular image is a central dot sign. Okay, what is this? This is what is a central dot sign, and the diagnosis of this particular patient is your Caroli's disease. Okay, so what is this? This is what is a cholecystectomy cyst type 5, which is Caroli's disease. Okay, and what you're basically finding over here, we have a central dot sign. Okay, so what are you basically finding over here? We are finding a central dot sign over here. Am I making some sense to you guys? Okay, so what are you basically finding over here? We are finding a central dot sign, Caroli's disease, cholecystectomy cyst type 5, central dot sign. I hope you are able to understand this point. Now, if at all, yeah, so you have this particular stuff, central dot sign, Caroli's disease, cholecystectomy cyst type 5, all those particular stuff. What is the treatment of choice for the Caroli's disease? Now, can you please help me? Well, yes, it is transplantation, guys. Okay, so the treatment of choice for the patients with the Caroli's disease is your transplantation, and I hope you're able to appreciate that this is what is a central dot sign. So I hope, okay, I'll just explain you how it is. So let's say if at all this is a cyst, in the center of the cyst there is a central dot. Okay, so you have multiple cysts, and in all these particular cysts what you have is a central dot. Okay, so the arrows are basically showing you the central dots, and these central dots are what? So these are basically the hepatic arteries. Okay, so the contrast which is basically going in the hepatic artery, so this central dot sign is basically seen in the contrast enhanced CT scan. On the CCT you basically get this central dot sign. Okay, I hope you are able to appreciate this particular point, guys. Okay, now what is the diagnosis of this particular patient? So over here you are getting an image. So what is this? Is what is a radio labeled iodine scan. Okay, so what you have performed is a radio labeled iodine scan, and what I'm trying to ask you, what is the diagnosis of this particular kind of patient? Is it like the Graves disease, toxic adenoma, papillary calcium-thyroid, or the Riedl's thyroiditis? What you need to understand. What is the answer over here? Okay, so guys, those of you who are answering the Graves disease, it is not correct. The answer over here is a toxic adenoma. Okay, so what is this? This is what is a toxic adenoma. So what is this? This is what is your hot nodule. Okay, this is what is your hot nodule. Okay, so whenever you get an image like this, what you basically need to do, you have to complete the thyroid gland like this. Okay, now you will be able to appreciate that this particular part of the thyroid is having the uptake which is more as compared to the rest of a thyroid gland. So why? That is why this is what is your hot nodule. Okay, so what is this? This is what is your hot nodule. Are you understanding my point? Now, why this is not the Graves' disease? Because in the Graves' disease, what is going to happen? The entire thyroid gland is going to have an increased uptake. So in the Graves' disease, the entire thyroid gland is going to have an increased uptake. But over here, what you have is, you basically have what you call as a toxic adenoma. So this is what is your hot nodule. Are you understanding my point? Please understand and please remember this. In the Graves' disease, the entire thyroid would have had the increased uptake. Okay, इसमें treatment क्या होगा? So see, try to understand. Toxic adenoma is because of various reasons, right? So you have to kind of do an FNAC and you have to kind of find out what is the problem of that. Maybe there is some malignancy, maybe it's just a benign kind of a like hyperactive nodule. So after you get the report of the FNAC, then you will kind of determine the treatment. If at all it's a benign kind of thing, you can perform an hemithyroidectomy. If at all, let's say there is a malignancy, then you will have to perform a near total or a total thyroidectomy. Okay, and yeah, in the patients with the Graves' disease, the entire thyroid will have an increased uptake. So that is what is the difference. Okay, yes, absolutely right. So Priyanka is basically trying to explain that there is going to be a uniform uptake if at all there is a Graves' disease. Okay, in the Graves' disease, there will be a uniform uptake. Okay, right. Now, what is the diagnosis of this particular patient? Cervical tuberculosis, thyroglossal fistula, branchial fistula, or boy. Okay, so what is the diagnosis over here? Think about it. Okay, think about it and then answer. So yeah, I'll just zoom in. What is the answer over here? So please try to understand. Yes, somebody has given the right answer. Okay, so Kumar gave you the right answer. So the answer over here is a branchial fistula, guys. Okay, it is not a thyroglossal fistula because it is not the midline swelling. Yeah, like if at all it would have been a midline kind of opening, then you would have thought about the thyroglossal fistula. And if at all they wanted to mark you as a thyroglossal fistula, first of all, they will give you a midline kind of a fistula, and then they will also tell you that, you know what, it is moving with the deglutination and the protrusion of the tongue. But over here, they did not give you all these things. So what is this? This is what is a branchial fistula. We talked about the branchial cyst, right? So branchial fistula is also the remnant of your second pharyngeal pouch. Okay, so this is again a remnant of your second pharyngeal pouch. So let's talk about the branchial fistula. Okay, so branchial fistula is again the remnant of your second pharyngeal pouch. So it is again a remnant of your second pharyngeal pouch. So this is again a remnant of the second pharyngeal, whatever the pouch or cleft, whatever you want to call it. Okay, and here what you need to understand is that there is going to be the opening which is going to be there on the anterior border of the sternocleidomastoid, and this particular opening is going to be between the lower 1/3 and the upper 2/3. Okay, so there's going to be the opening which is basically present at the level of, like on the anterior border of the sternocleidomastoid between the lower 1/3 and the upper 2/3. Okay, so the branchial cyst was again present on the anterior border of the sternocleidomastoid, but that was basically present between the upper 1/3 and the lower 2/3. But over here in the branchial fistula, the external opening is basically present on the anterior border of the sternocleidomastoid, and this particular opening is between the lower 1/3 and the upper 1/3. Okay, I hope you're upper 2/3. Okay, so please appreciate this particular point, guys. Okay, so let's say this is a sternocleidomastoid over here. The opening is basically on the anterior aspect, that's fine, but this is basically present between the lower 1/3 and the upper 2/3. Okay, so this is what is your branchial fistula. I hope you are able to appreciate this point. Okay, right? Okay, now what is the diagnosis of this particular patient? Okay, so here what you are basically having is an arteriography. Okay, so what you have is arteriography. So if I ask you what is the diagnosis of this particular patient, can you please help me with this? What is the diagnosis? Yeah, guys, what is the diagnosis of this particular patient? So the diagnosis of this particular patient is what? Yeah, come on, guys. What do you think? What is the diagnosis of this particular patient? Yeah, it's a Liar's sign. What is this? This is what is a carotid body tumor. What are you basically saying is this is what is a carotid body tumor. And what is this particular sign called as? This is what is called as a Liar's sign. Okay, so what is happening in this? That you have this particular common carotid artery, right? So you have this particular common carotid artery, and then what we have is this is what is an external carotid artery, this is what is an internal carotid artery. So there is a splaying of this particular external and the internal carotid artery along this particular carotid body tumor. Are you understanding my point? So the splaying of the arteries, this is what is a diagnostic feature of your carotid body tumor. Okay, I hope you are able to understand this particular point. Okay, now if I ask you what is an investigation of choice for this particular carotid body tumor, What is an investigation of choice for the carotid body tumor? Can you please help me with this? What is the investigation of choice? It is this, arteriography. Arteriography. So please do not mark it as a biopsy or an FNAC, right? So biopsy or FNAC are contraindicated. Okay, so they are absolutely contraindicated in these particular patients. Okay, so please try to understand over here, it is absolutely contraindicated in these particular patients. Why? Because if at all you end up kind of doing an FNAC or kind of biopsy, you might end up injuring the carotid vessels and might be a lot of bleeding over here. Okay, so that is why the biopsy and the FNAC are absolutely contraindicated in these particular patients. Very, very important. Liasign carotid body tumor. Okay, now this is not a very easy kind of a thing, but you would have heard of these, you would have read of this. So let's try to kind of have a look at it. Okay, so what is the diagnosis of this particular patient? First, look at the options: malakoplakia, schistosomiasis, what you call as like secondary bladder calculi, and the squamous cell carcinoma. Okay, and I'm trying to show you the image over here. Okay, so this is the image which are basically. Okay, good. Many of you guys are answering it properly. So answer over here is the schistosomiasis. Okay, what is the schistosomiasis? So what is this called as a? This is what is called as a fetal skull in the pelvis appearance. Okay, so what is this? This is what is a fetal skull in the pelvis appearance. So what is this, guys? Okay, doesn't it look like that there is some fetus? Okay, so don't you think that this is the like the skull of the fetus? Okay, so this is what is the fetus which is basically present in this particular female. Okay, you understand my point? So this is what is the characteristic fetal skull in the pelvis appearance. This is what you basically get in the patients with the schistosomiasis. So what happens in the patients with the schistosomiasis is that there is a bladder wall calcification. Okay, in the schistosomiasis, what you need to understand is that there is a bladder wall calcification. Okay, what you basically get in these particular patients is we get a bladder wall calcification. Okay, so what you basically get is a bladder wall calcification, and that is what is that is what is giving you this fetal skull in the pelvis appearance. Now if I ask you about the schistosomiasis, is it a risk factor for some malignancy? Okay, so please tell me, is it a risk factor for which malignancy? So schistosomiasis per se is a risk factor for which malignancy? Like which type of the bladder cancer? Squamous cell cancer, adenocarcinoma, transitional cell carcinoma. So it is a risk factor for what? So please try to understand, this is a risk factor for the transitional cell carcinoma as well as the squamous cell carcinoma, but it is a more important risk factor for the squamous cell carcinoma. This is more commonly associated with this squamous cell carcinoma. Okay, so please try to understand, the schistosomiasis is a risk factor for both transitional cell carcinoma as well as the squamous cell carcinoma, but it is more commonly associated with the squamous cell carcinoma. Okay, right. Now which kind of a needle is shown in the following kind of a figure? Is it like the cutting needle, reverse cutting needle, taper cut needle, or the round body needle? Okay, so look at this particular image. What kind of a needle has been shown over here? Is it like the cutting, reverse cutting, taper cut, or the round body needle? Okay, so what do you think? What is the answer over here? Okay, so yes, it is basically a cutting needle, guys. Okay, what is this? This is what is a cutting needle which we have over here. What is this? We have a cutting needle over here. Okay, very important. Okay, very important. Okay, so let's try to talk about the needles a bit. Okay, so what you need to understand is that you have a two types of needles. So you have a cutting needle and you have a round body needle. Okay, round body needle. So the cutting needle can be of two types. Cutting needle can be either a kind of a classical cutting needle. So it can be a classical cutting needle, or they can be a reverse cutting needle. Okay, so what about this particular classical cutting needle? So let's kind of focus on these particular images now. Okay, so if at all you have this particular needle, and on the cross section, if at all they show you that it is like a vertical triangle or an erect triangle, that is what is a classical cutting needle. What about the reverse cutting needle? Over here you get an inverted triangle. Okay, so reverse cutting is basically an inverted triangle and the classical cutting is basically an erect triangle. Are you understanding my point? So please try to understand, reverse cutting is like this, classical cutting is like this. Okay, I hope you have understood this particular point. Right now, Where do you use this particular cutting needle? Where do you use this particular cutting needle? Whenever there is a tough structure and you want to basically enter into the tough structure. For example, the skin, okay, or the sheath, okay, or let's say the tendon. Okay, so if at all you want to enter into the tough structure, then what you basically end up using is a cutting needle. Okay, cutting, reverse cutting, all those particular stuff. Even for the vascular surgery, okay, please try to understand vascular surgery. Let's say if at all you want to do a vascular anastomosis, there what you basically use is this reverse cutting needle. Okay, reverse cutting is basically used in the vascular surgery. Please try to understand over here. Okay, what about the round body? In the round body, what is there? That it is like a bit less traumatic because it is going to split the tissue. It is not going to cut the tissue. So this is basically used where you have a soft tissues, like for example the muscle or the mucosa. Okay, so there you are basically going to use this round body needle. Okay, so here what they are going to show you in the cross section, they're going to show you that there's something like this. Okay, so this is what is a round body, but the round body can be with, let's say, like, so if at all they show you like this. Okay, if at all they show you image like this. Okay, so they show you that there is a round body needle, and over here they say that it is blunt. So this is what, this is a taper blunt. Okay, now if at all they show you that this is a round body and there is like this, so what is this? This is what is your taper point. Okay, this is what is a taper point. Okay, and if at all they show you the image like this, taper, and this is like a cutting, the end is basically made like a cutting. Are you understanding my point? So this is what is called as a taper cut. Okay, so what is this called as? This is what is called as a taper cut. Are you understanding my point? So we have a taper blunt, we have a taper point, and we have a taper cut. Please remember these, at least these three images, and this classical cutting and the reverse cutting. At least these things, it is must for you to remember. Please remember these points. Okay, taper blunt, taper point, taper cut, and classical cutting, reverse cutting. Okay, please do remember this. Okay, now what is the sign which is being shown in this particular kind of an image? Okay, so first of all, what is this investigation? What are you basically seeing? And then you can tell me the sign. What is this particular sign? Okay, so what is this? This is what is an MRI. Okay, this is what is an MRI, and what are you basically seeing on these particular MRI is a breast implant. Okay, what is this? This is what is a breast implant. Okay, and what is this? This is what is a ruptured breast implant. Okay, so what is this? This is what is a ruptured breast implant. So this is the ruptured breast implant. This is what is the normal breast implant. Okay, this is what is a normal breast implant. This is what is a ruptured breast implant. So what is this? This is what is called as your so this is what is called as your linguine sign. Okay, so what is this? This is what is a linguine sign, and yeah, that is what you need to understand over here. Normal breast implant, ruptured breast implant, linguine sign. Okay, I hope you are able to understand intracapsular rupture of the breast implant. Okay, linguine sign. Okay, got it, right? Okay, now if I ask you what are the indications of an MRI? Okay, so what are the indications of MRI? Indications of MRI in the breast. Okay, so what are the indications of MRI in the breast? The indications of the MRI in the breast are familial breast cancer. Then what else? Okay, so first is the familial breast cancer. Then let's say if at all there is a multifocal tumor versus unifocal tumor. Then breast implant, recurrence, so scar recurrence. Okay, scar recurrence. Then what else? So so ductal carcinoma in situ and ductal papilloma. Okay, so please understand these particular point. Okay, so these are the indications of performing an MRI in the breast. Okay, so please remember these are very important. This list is very important. Familial breast cancer, for example, if they give you that there is a female whose mother died with a breast cancer and now you want to screen these particular patients. So in the familial breast cancer patients, for the screening purpose, what you basically use is an MRI. Okay, so please do remember this particular stuff. It is very important. Okay, got it? Okay, now there is a child. Okay, so what is not visible on your screens is the child is coming to you. So this is what is a child, guys. Okay, so child is basically coming to you with a severe abdominal pain, and there is a bilious vomiting in these particular patients, and there is an intestinal obstruction. The ultrasound has been shown to you. What is the diagnosis of this particular patient? Yes, absolutely right. This is what is a target sign, and what you're basically seeing over here is a intussusception. Okay, so yes, absolutely right, absolutely good, guys. So what is this? This is what is an target sign. This is what is an intussusception. Now if I ask you that what is the another sign which you basically find in these particular patients on an ultrasound? Okay, so let's kind of revise the signs which you basically get in these particular patients. Okay, so on the barium enema, okay, barium enema, what are you going to find in these particular patients? So in the barium enema, you're going to find the claw sign. Okay, what else you're going to find? You're going to find a coiled spring appearance. Okay, so claw sign and the coiled spring appearance. This is what you're going to find on the barium enema. What are you going to find on the ultrasound? Okay, so if at all you perform an ultrasound, what you're going to find on an ultrasound? On the ultrasound, what you're going to find is a pseudo kidney sign, and the target sign. Okay, target or the donut sign. Okay, target or the donut sign and the pseudo kidney sign. This is what you're going to find on an ultrasound. Okay, and on the plain X-ray, what are you going to find? On a plain X-ray, you are going to find what you call as, on the plain X-ray, you are going to find a air crescent sign. Okay, so what you're going to find on the plain X-ray, you're going to find the air crescent sign. Okay, so please try to understand these are the things which you're going to find in the patients with on the barium enema, on the ultrasound and on X-ray. These are the things which you're basically going to find. Okay, I hope you're able to understand this point. Okay, now what is the diagnosis of this particular patient? So you have an X-ray which is basically present just behind me. So what is the diagnosis of this particular patient? Okay, so is it like the hemothorax, pneumothorax consolidation, or the hemo, whatever the, yeah, so hemopneumothorax? Okay, so what is the diagnosis over here? Can you please help me with this? Very, very important, very simple X-ray, but an important X-ray for all of you guys. Okay, so can you please help me? What is the diagnosis of this particular patient? Okay, so yes, it is a pneumothorax. Okay, very good. Okay, what is this? This is what is a pneumothorax. So what you're basically appreciating over here, that this particular part of the lung, this is more black as compared to the other side. Okay, so this is more black. Why this is more black? Because what you need to understand, the lung has collapsed over here. The lung has collapsed over here, leading this particular part more black. Okay, so this particular part of the lung is more black as compared to the opposite side because the lung has collapsed. Okay. Okay, so over here, what you're basically appearing this haziness, this is because of the bronchovascular markings. Okay, because of the bronchovascular markings, and this is what is a kind of a diagnosis of your pneumothorax. Now, I understand that whoever is kind of watching, 90%, 95% of you guys must be obviously knowing this is a pneumothorax. But for those 5%, please try to understand over here. If you commit a mistake on the question like this is absolutely kind of not acceptable at all. Okay, so please try to appreciate the X-rays of a pneumothorax and the hemothorax. Here, what you need to understand is that this particular part of the lung is more black as compared to the other, and you have a collapsed lung over here. So this is what is a pneumothorax. In the hemothorax, what you're going to find is that you're going to find a white out lung. On the hemothorax, you basically find a white out lung. Okay, I hope you are able to understand this particular stuff, guys. Okay, got it? Okay, good. Now let's move on. What is this investigation? Okay, so yeah, what is this investigation? Okay, now again, like not a very, it's more of a radiological question rather than a surgical question. Okay, so first tell me the investigation, and then you can basically tell me about what you call as the diagnosis of this particular patient. Okay, okay, so okay, this is not a CT angiography, this is not an MR angiography. What is this? This is what is a digital DSA. What is this? Is what is called as a digital subtraction angio. What is this? This is what is a digital subtraction angiography. So what are you basically seeing over here? So please try to understand over here. Yes, you are appearing that the blood vessel is there, that's fine. But are you able to appreciate anything around it? Any soft tissue is basically visible? No. It is as if like the soft tissue has been subtracted out of this particular image. And this is what is referred to as your digital subtraction angiography. And what is the diagnosis over here? the characteristic string of beads appearance. Okay, the characteristic string of the beads appearance. So what is this? This is what is the diagnosis over here? Okay, so what is the diagnosis over here? The diagnosis over here is a renovascular hypertension. Which is like, this is what is the condition, and the diagnosis per se is called as a fibromuscular dysplasia. Okay, so what is this? This is fibromuscular dysplasia. Okay, so fibromuscular dysplasia or the renovascular hypertension, string of beads appearance. So what is this particular sign called as? This is what is called as a string of beads appearance. Okay, so this is what is called as a string of beads appearance. Okay, I hope you are able to appreciate these particular stuff, guys. Okay, so the diagnosis over here is a digital subtraction angiography, string of beads appearance, fibromuscular dysplasia, renovascular hypertension. Okay, I hope you are a fibromuscular dysplasia. Okay, yeah, that's fine. Okay, understood? Got it. There was one doubt I wanted to kind of address. Somebody has something, right? Just give me a minute. Somebody asked, okay, tracheal deviation. So Dr. Praveen is basically asking, so tracheal deviation. So he's saying that, so this is you're saying that this is a pneumothorax, that's fine, but what about tracheal deviation? So please try to understand, in the patients with the simple pneumothorax, tracheal deviation might not always be kind of there, or maybe it is there, but it is very, very slight. So it might not be kind of appreciated on this particular X-ray, that's fine. So but is it like that the tracheal deviation will never be present in the pneumothorax? No, that is not true. So please try to understand, tracheal deviation will be present in both simple pneumothorax as well as the tension pneumothorax, but the tracheal deviation will be more in the tension pneumothorax. Okay, it will be more in the tension pneumothorax as compared to that of a simple pneumothorax. In the simple pneumothorax, most of the times it will be there, but it may not be there. That's fine. So that's not big a deal. Okay, I hope you've understood this particular point, guys. Okay, understood? Got it? Now let's move to the next question. What is the procedure which you are basically seeing again just behind me? So what is this particular procedure? So what is the procedure which you are basically seeing just behind me? So what is this? Is it like, yeah, so you only tell me, what is the diagnosis? What is the procedure? Okay, Whipple's procedure. Okay, Beggar's procedure. Yes, what is this? This is what is a Beggar's procedure. So this is what is called as a DPPHR. So what is this DPPHR? DPPHR basically stands for duodenum preserving pancreatic head resection. Okay, so what is this DPPHR? Duodenum preserving pancreatic head resection. So what are you basically finding over here is that this small rim of the pancreatic tissue is kind of retained over here. Okay, so the small rim of the pancreatic tissue is retained. Why this particular small rim of the pancreatic tissue is retained? Because you want to kind of preserve the bile ducts. Okay, so these bile ducts you want to kind of preserve, and that is why, because if you kind of remove this particular pancreatic tissue from here, the bile duct will also be removed, and the patients might be needed to be subjected to what you call as a Whipple's procedure. You don't want the patients to be subjected to the Whipple's procedure, and that is why what you basically perform is this DPPHR, that is your duodenum preserving pancreatic head resection. Okay, so I hope you are able to understand this particular point over here. Okay, right? Okay. Okay, so yeah, that's what you need to understand over here. Duodenum preserving pancreatic head resection. Option B में क्या होता है, sir? Okay, so what is the option B? Option B is Pistor's procedure. Okay, I'll talk to you about that. Okay, so okay, what is the, okay, everybody have understood? First of all, have you understood this DPPHR? This is the resection procedure. So where do you perform these particular procedures? You perform these procedures in the patients with what you call as a chronic pancreatitis. Okay, in the chronic pancreatitis you perform this. So this is what is a resection procedure. DPPHR, duodenum preserving pancreatic head resection. This is what is a resection procedure. Okay, now let's talk about the Pistor's procedure. So what is this Pistor's procedure? Pistor's procedure is basically what you call as a longitudinal pancreatico-jejunostomy. Okay, so what you basically do is that, let's say if at all this is a pancreas, okay, and if at all there are okay, so when do you perform this particular Pistor's procedure? If at all the main pancreatic duct is dilated and there are multiple strictures and dilatations in the main pancreatic duct. So what you basically do is you open the pancreatic